We are good to go. So we are good to go.
Yeah. Very warm welcome to everyone. Good evening to all of you. Thank you all the participants joining in today. We have more than 60,000 registrations joined and done for this sixth annual national conference for the Fever Foundation FEFCON 2023. We had a successful day one with celebration joining in from the keynote address from Dr. Soumya Swaminathan. We had a GC Surana oration from Dr. Narsimlu. Also, we had fantastic lectures from Dr. Ram, Dr. Chandrasekhar, Dr. Camila Rodriguez. And today we are looking for feast of events. We have two different halls, one for the pediatrics and another for the physicians. And the viewers who are logged in through the virtual hall can toggle through both the halls, physician as well as pediatrics hall. And we are live coming in from the pediatrics hall now. We have the first session going on. We'll start with the first session today with Dr. Pramod Kulkarni sir joining in and Dr. Chetan Trivedi being the chair for the first session of the day today, that is pathogenesis of fever. To chair this session, we have our Dr. Chetan Trivedi. He's been one of the founding members of the Fever Foundation and also been very active and also the man behind one of the all the scientific activities of Fever Foundation. Dr. Chetan Trivedi is a practicing pediatrician and neonatologist from Ahmedabad. He has several accolades, several research papers, ardent speaker at various forums. He has an active role in IAP. He's also been the uh, joint secretary of IAP. He is also the treasurer. He is also organized secretary of the recently Pedicon 2023 as well. He has also been part of the many national modules of IAP. Chetan sir, it's over to you to chair the session and take over, sir.
Thank you, Dr. Krishna. At the outset, I would like to thank the Fever Foundation for this wonderful attempt of a continuous sixth FEFCON. And maybe when we launched this first concept of the conference on fever, people were just struggling to understand why and what will you be able to do under the heading of fever only. And now we have been so successful that we are in the sixth year. So with a huge viewership, so that's kudos to the whole team which is behind this FEFCON. And we know that this is the sixth fever conference, FEFCON 2023. We have a theme that is, bench to bedside, the fever bench to bedside. So that's why we start from something, from the basic, and ultimately we reach out to our patients. And for that matter, I think we know that we are just going to deal with fever, but we should be knowing what is the pathogenesis of fever. Because once we understand the pathogenesis of fever, I think then we can definitely correlate it with the clinical conditions, the diseases, and particularly management of fever. Because it's not just giving something the treatment of, we want to break that myth that fever is equal to antibiotics. So there we want to introduce the concept of, rationality. So first we will be talking about like pathogenesis of fever, and for that we have a wonderful person, a nice human being, a good friend, Dr. Pramod Kulkarni. It's my proud privilege to introduce Dr. Pramod Kulkarni, sir. He is been the expert in ID, particularly because he has already been, he's a MD and MR CPCH from UK. He's done the diploma in pediatric infectious disease from Oxford. And he's been consultant pediatric infectious disease at KM Hospital and Dinath Mangeshwar Hospital, at Unique Hospital, SKN Medical College, and Smile Clinic at Pune. And we all know that his area of interest is pediatric infectious disease, clinical practice, even general pediatrics. He's been talking a lot about the general pediatrics and infectious disease. So it's a treat to listen to him. He's been associated with the infectious disease chapter of IAP. He's been consistently and continuously for third year been elected as a Central IAP Executive Board member 22 to 24. So congratulations to you, Dr. Pramod, sir. He's been on the board of IAP Infectious Disease chapter from 2009, again in 2021. He has been contributor to many books, many chapters in the many books, and also he has designed few good modules also. He has wonderfully been designed last module, I think good practices module, which is going very nicely all across the country as a IAP presidential action plan. So it's really going to be a really treat to listen to Dr. Pramod sir on pathogenesis of fever. Welcome, Dr. Pramod.
Thank you so much, Dr. Chetan, for all those good words about me. Good evening, everybody, and welcome all the attendees, delegates of this PepCon. And it's really a privilege to be here. And thanks to the organizers for inviting me to deliver about the pathogenesis of fever. So this is going to be a brief presentation to relearn about pathogenesis of fever, which is going to help us to understand how fever occurs and what are the various physiological and physical mechanisms to deal with the fever, which is a element troubling everybody in the pediatric practice as well as the society as well. So let's start with the presentation, please. Next one, please. So let's relearn some basics about fever. Please go ahead. So what is fever? It represents a complex adaptive response of the host to various immune challenges. It is defined as a regulated rise in body temperature above normal daily fluctuations with an elevated thermoregulatory balance or set point. That is the most crucial part of it. It is also accompanied by various sickness behaviors, changes in metabolic and physiological and immune responses of body attributable to its multi-systemic effects through highly coordinated endocrine, neurological, immunological, and behavioral mechanisms. Let us keep apart the hyperthermia, which really means body temperature elevated without a corresponding rise or change in the thermal set point in the hypothalamus. Next slide, please. So let us look at the basic thermoregulation, which is the most important concept. Body temperature is kept within a normal regulated limit by a delicate balance between heat loss and heat gain mechanisms. Go ahead, please. Which is dependent on the thermoregulatory circuitry of various relatively independent thermoeffector peripheral and central neural loops. That is important. Neural loops sending temperature signals to integration in the major thermoregulatory center located at the pre-optic region of the anterior hypothalamus. It consists of heat-sensitive neurons, warm and cold type, activated or inhibited in response to temperature changes, cold or hot. Next slide, please. So look at the hypothalamus, the central thermoreceptors and peripheral thermoreceptor sending the inputs to the hypothalamus. And how does it? It integrates all the inputs from the peripheral and central thermoreceptors and takes a decision and makes changes depending on the inputs, whether it is hot or cold input in temperature reduction mechanism and temperature generation mechanism. That's a basic balance between these two mechanisms. So the temperature reduction mechanisms operate through sweat glands and the vasodilator mechanism of the autonomic system, as well as the temperature generation mechanisms mainly consist of increased metabolism of the liver, the muscle, as well as the adipose tissue, and which further increment the temperature generating process by heat production and shivering. Next slide, please. The cold environments, cold sensitive neurons increase firing and warm sensitive neurons decrease firing, which leads to activation of heat gain mechanisms and prevention of heat loss mechanisms. While, next one please. So it occurs through skin vasoconstriction, piloerection, decreased sweating, increased muscle contraction, non-shivering thermogenesis, seeking warm clothing or environment behavior. While exposure to heat, it leads to warm sensitive neuron increase firing and cold sensitive neurons decrease firing, leads to activation of heat loss mechanism and inhibition of heat generating mechanisms through various physiological processes. Next slide, please. And this is the difference. Hot, there occurs vasodilatation. In response to hot, vasodilatation occurs, sweating occurs, pylorelaxation occurs, and the other mechanisms which facilitate the heat dissipation mechanism. When exposure to cold, vasoconstriction of the vessels occurs, shivering occurs, piloerection occurs, and curling the posture to decrease the surface area and to conserve the heat occurs. Next slide, please. And let us look at the basic systems of this. The active system of the thermoregulation is mediated through shivering, vasoconstriction or dilatation, and sweating, as well as the metabolic rate. While the passive one is the exposure to the environment and dissipation of heat through respiration, radiation, evaporation, convection, conduction, mediated through the peripheral vasoconstriction or vasodilatation. Next slide, please. And let us look at the exogenous pyrogens, which are the initiating factors. They get attached to the first line immune response, that is innate immune cells, and generate pyrogenic cytokines as well as ceramides, which directly act on the hypothalamic center, which is the preoptic area. Simultaneously, the similar macrophage and monocyte activation leads to generation of the PGE2 in the liver as well as lung and the other tissues, which directly act on the preoptic area of the hypothalamus, which sends signal to the anterior hypothalamus, which fires the neuron and which results into fever. Next slide, please. And let us look at the cascade of it. It is a microbial agent, their products, and the pathogen associated molecular patterns, which are the key in inducing the cytokine response. Similarly, apart from the infectious organisms, trauma, ischemia, and hypoxia can lead to initiation of this cascade. The TLR of the innate immune cell, macrophages, endothelial cells, and reticular endothelial system get activated. They release the pro-inflammatory pyrogenic cytokines, that is IL-1, IL-6, TNF-alpha, and interferon, which further leads to transport through circulation to the hypothalamic centers. And there the endothelium, which is highly responsive to the temperature changes, leads to cytokine receptors engagement with these and ELR engagement, leading to prostaglandin E2 synthesis. This prostaglandin E2 synthesis is the key factor which leads to resetting the thermostat as well as the vasomotor center, leading to heat conservation as well as prevention or decrease in the heat dissipation mechanisms. And you will see various inhibitors working at different levels of this cascade. Corticosteroid act inhibitory at the release of the pyrogenic cytokines. Antipyretics are inhibitory to the PGE2 synthesis and the next cascade. Next slide, please. So let us correlate it to the fever physiology. So there are three phases of fever. One is prodrome, during which the cytokine and the chemical cellular level changes occur, which leads to febrile phase when the fever sets in. Body temperature is below set point and the body processes which increase the heat conservation and decrease heat dissipation lead to chills. And thereafter, at one point, when there is a balance between the set point as well as the body temperature, then the defervescence process starts. Either by natural dissolution or antipyretic, the defervescence starts, and again the sensors of the hypothalamus sense that the body temperature is equal to the set point, and the heat dissipation mechanism start in bringing down the temperature, and the host flushes, and finally the defervescence sets in and temperature comes down to the original level. Next slide, please. Pyrogens are the key febrile response inducers and mediators. Most of them are endogenous pyrogens, which are most important. Those are produced by activated immune cells, neutrophils, macrophages, lymphocytes, endothelial cells, astrocytes, and glial cells of the CNS. They are pro-inflammatory cytokines, interleukin-1, interleukin-6, TNF-alpha, interferon-gamma, and granulocyte monocyte colony stimulating factors. They activate neutrophils and further carrying of the inflammatory and febrile response. Its overproduction may be harmful sometimes, leading to shock, multi-organ dysfunction, and death. Usually, they are induced by exposure to exogenous pyrogens, but sometimes, occasionally, there can be non-induced endogenous pyrogens, which are antigen-antibody complexes and some other mediators. Next slide, please. Acute phase response, febrile response is part of acute phase response. It encompasses hematological, endocrine, and metabolic changes that follow within hours or days of the onset of fever in response to inflammation due to infection or local damage to your tissue. The fever is the first thing to come in, and the acute phase reaction come at various different times across the evolution of the inflammatory process. They are induced by several cytokines, mainly IL-6, which are beneficial to the host. Various acute phase proteins, notably CRP, serum amyloid A, are synthesized by hepatocytes and released into circulation in large amount. Next slide, please. CRP plays a role in complement activation, opsonization, and increasing platelet aggregation. CRP levels can be normal in febrile viral infection and high in disease without fever as well, like in tumors, ischemia, and trauma as well. There is reduced albumin transferrin synthesis as well as concentrations of iron and zinc also reduced, while copper concentration increases. This is immune protection to deprive the organisms, offending organisms, of their essential nutrients and to bring down their growth. Next slide, please. Microbial pyrogens. Let us look at various microbial pyrogens. Gram-positive bacteria, essentially the cell wall peptidoglycan is the chief pyrogen. Gram-positive cocci, like in scarlet or TSS, exotoxins stimulate macrophages monocyte to release IL-1. Gram-positive bacilli, the exotoxins are less fever-inducing. So these illnesses are not marked by very high fever. Pneumococci usually exhibit their febrile response to immunologic process. Spirochetes attach to mononuclear cells to induce IL-1 production. In gram-negative bacteria, the classic prototypes being Salmonella E. coli have heat-stable factor endotoxin LPS in outer membrane protein that causes a dose-related progressive increase in temperature. And in severe cases, it can really lead to vasodilatation, capillary leak, shock, and hypotension. Septicemia caused by gram-negative endotoxin need not elicit fever where there is an immune compromise or the host is immune compromised, where the ability to generate pro-inflammatory mediators is compromised. Next slide, please. Next slide, please. Microbial pyrogens, again, viruses, direct invasion of macrophages, immunological reaction to viral components involving antibody formation, induction of interferon and necrosis of cells by virus. In fungi, live or killed fungal products induce fever, mainly in bloodstream or invasive infection, not the superficial localized infection. Children with neoplastic disease are especially at the risk of the fungal infections with less febrile response. Next slide, please. Non-microbial pyrogens, there are many. As in case we see non-infectious conditions, blood transfusion reactions and immunohemolytic anemia, type 2 hypersensitivity and phagocytosis cause fever. Type 3 hypersensitivity plays a major role in antigen-antibody complex formation. An exogenous antigen may react with circulating sensitized antibodies to form a complex which induces IL-1 production, as in case of SLE and many drug fevers, classically in case of penicillin-induced fever. Other non-microbial pyrogens are also there. Some hormones, drugs, intracranial lesions like bleed as well as thrombosis. There are some odd steroids in adrenogenital syndrome can induce fever. Next slide, please. So what are the determinants of the final outcome of this febrile response? The initiation, manifestation, regulation, height and duration of the febrile response depends on the balance in the interactions of pyrogens and antipyretic chemical substances. Those are cryogens, various exogenous and endogenous substances. While pyrogens directly or indirectly lead to fever, cryogens prevent excessive temperature elevation. That is classically anti-inflammatory cytokine IL-1, receptor antagonist, IL-4 and IL-10. Those promote healing and reduce inflammation. The source, site, quantity, potency, type of pyrogen, and cryogens, that is, etiology and host status, are critical in clinical manifestations of febrile response as a part of inflammatory response. Next slide, please. Is fever good or bad? Fever may provide protection by several mechanisms. It is offered as the evolutionary protective mechanism against the microbial invasion of human host. Elevated host temperature inhibits microbial reproduction, increases antimicrobial activity of many classes of antibiotics, may increase in innate immunity and microbial destruction. That is the chief protective mechanism. But fever more than 40 degrees centigrade, a further mortality increase has been noted, suggesting deleterious effect of hyperthermia on organs and cellular function, which outweighs any benefit of fever. Non-pyrogenic fever is not of any perceived teleological benefit. In ICU, rising trend towards increasing fever is always associated with worse outcome. Next slide, please. So finally, friends, fever is highly coordinated, complex, biological multisystemic response to immune challenges. The peripheral and central neurohumoral pathways and hypothalamic thermoregulatory center regulate active febrile response and the thermal balance. Exogenous pyrogens, mostly of microbial origin, and endogenous pyrogens generated by the immune cells are the key mediators of febrile response. Fever has definite protective benefits within limits. In certain critical conditions, it can have deleterious effects, and that is about the pathogenesis of fever to be applied in individual conditions. Thank you very much. Thank you so much, the organizer and all the attendees. Thank you.
Thank you, Dr. Pramod, sir. That was an excellent presentation about pathogenesis of fever. And we know that now how the fever actually arises. And that's why when to use the antipyretic, which antipyretic that we should be doing. Well, ultimately, it's a PGE2, which is a culprit which you have to inhibit. And there, our all antipyretics, they work. And one thing which was very interesting to understand from your talk is something is called thermoregulatory set point. Because what happens that whenever the body is having certain thermoregulatory set point, which has been set by the body, that means if the thermoregulatory set point is 102, then body has to do the changes in their own so that the body rises the body temperature to 102. So if you try to decrease that set point, then again, the reverse mechanism will occur and temperature will go down. That's a flushing, and that is very nicely been explored. And that's why we know that whenever there is a hyperpyrexia or heat stroke we are seeing, whenever there is external heat which is coming up, so there is no set temperature has been changed. So even if you give something like antipyretic, it's not working. So it's then external cooling is important. So that's the importance of understanding that pathogenesis of fever. That's fever, this thermoregulatory set point. It is very important. So excellent presentation, Dr. Kulkarni. And if there are any questions, we'll be taking. Otherwise, we can move to next. Thank you.
Chetan sir, there is a question coming in from on the platform. This is a question from a PG student from Ajmer.
Yeah.
The student is asking regarding the same thermoregulatory set point. Sir, are there any drugs or should we wait till 102 degrees then we start the antipyretics, or how is it, sir? That's a question from a Ajmer PG student.
Number one, there are two determinants of this question. Is the child the exceptional case of critical child or with major organ dysfunction or failure? In which case, the little tip off because of the fever, metabolic cost which is extra due to fever is going to be deleterious. Apart from that exceptional case, fever degree or rise has nothing to do with the outcome of fever. It solely depends on the underlying cause. And degree of fever really has nothing to do with the outcome of normal or routine garden type febrile patient.
Yeah. At the same time, when the temperature is 102, that means you need to decrease that. Even if the child is not comfortable, if you want to make the child comfortable, if you want to reduce the temperature degree, then you give antipyretic. That will decrease your set point, and that's why the temperature will come down. Child will become comfortable. Whatever antipyretic we give, we should be knowing that it will decrease the temperature maybe in the tunes of 1 to 2 degrees centigrade, not more than that. So never expect it to be 98.4 once you give the antibiotics. So that's not been targeted. It is just to make the child comfortable. That's the only concept. Yes, Dr. Jagdish Sinappa, sir.
Thank you, Dr. Pramod, for that wonderful lecture, really revealing about many of the pathogenetic mechanisms in fever. I have only one question for you, and that is, see, for the same infectious disease or the same infection, different children manifested different degrees of elevation of temperature and for different durations of time with the same infection. Now, why does this happen? Is this because they are producing a different level of the IL-6 and other pyrogens, or are there any genetic differences in the hypothalamic response to the pyrogens?
Thank you very much for that great question, sir. And the answer is both ways. There are two determinants of it. So again, about with the same stimulus, responsiveness of individual totally depends on constitution and training, or let us say exposure of the immune system of that individual. And both are determined, as you rightly said. There are genetic variations in the responsiveness, as well as there are variations in the anatomical or structural responsiveness to the same degree of stimulus. And this is the area of exploration the current updates are going about. And we are not with any final answer now, but as you rightly said, you expect different kind of response from individual, and it's not a patternized, predictable, high degree response in every time.
Thank you. Thank you.
Thank you, sir. Thank you for the wonderful lecture there. Thank you, Chetan, sir. We also have other chairpersons, other Fever Foundation members joining in. We have Dr. Anand Vasudev, sir, and Dr. Yagnesh Popat, sir, who have been key and instrumental in all our scientific activities. Welcome, sir. And also, I forgot to introduce our organizing chairperson and the main man, Dr. Jagdish Sinappa, sir, here. Sir, apologies. Thank you, sir. And also, we have the Pramod, sir, thank you for your wonderful lecture there. And we have the next speaker coming in, Dr. Padmasani madam there. And also to chair the session, we have Dr. Yagnesh Popat, sir. Dr. Yagnesh Popat, as I told, is one of the founding members of the Fever Foundation. Practicing medicine in drug. Yes. Yeah, he has been the chairperson, IAP ID chapter, national vice president of IAP, also national executive board member. He's been the
Fine,
president.
Krishna, there is no need for further introduction.
Yes,
It's the privilege of the speaker at present. So,
yes, sir. Thank you, sir. Thank you. It's over to you, sir.
Yeah. So, good evening, one and all respected seniors in the crowd, Dr. Chinnappa sir, Dr. Sukumaran sir, Dr. Anand Vasudevan, Dr. Chetan, Dr. Pramod Kulkarni, and Dr. Padmasani. Dr. Ravi Shankara, please. We move on to the next session without wasting much of the time. And to enlighten us on the next session is on the viral URTI. Friends, URTI plays a major role in the infection, especially in the early childhood, maybe 3 to 4 episodes a year. And majority of them are the viral origin. So this is the day-to-day affair for all of us. And to enlighten us on that particular subject, we have Dr. Padmasani Venkat Raman. She is a professor of pediatrics, Sri Ramchandran Institute of Higher Education, Chennai, and her special interest is in the infectious disease and nutrition. She is a coordinator for a fellowship program, which is run by the Pediatric Infectious Disease of Indian Academy of Pediatrics. And she is to her credit, many publications in the books, book chapters, national and international articles. So I invite Dr. Padmasani to deliver her talk on the subject viral URTI. Welcome, madam.
Thank you so much, sir, for the kind words of introduction. And I thank the organizers for giving me this opportunity. May I request the team to share the first slide? Dr. Popat has already highlighted the importance of viral respiratory infections in pediatrics. So in my presentation, I'll be talking about common cold and influenza, the disease burden of these two conditions, etiology, clinical features, most importantly, the differential diagnosis, what is not a viral upper respiratory infection, and then the management of both the conditions along with prevention. Dr. KK, I think you're sharing the older version of my slides. Do you think you can go on to the newer version?
Just a second. Shruti? Ma'am, also, I think there is an issue with the cord there. If you can remove the cord and use the speaker directly, ma'am.
I'm using the PPT which I have received on the mail on 5:53 p.m.
Today?
Yeah.
Okay, please go ahead. When you say cord, you mean my earphone? Am I audible? Okay, please go on to the next slide.
Ma'am, if possible, can you remove your earphones if you're using any? That would be better because there is a lot of disturbance in your voice.
Is it better now?
Yeah, much better. It's clear. Thank you.
Okay, fine. So upper respiratory tract includes the nose, the paranasal sinuses, the pharynx, the larynx, and the large airways. So when we talk about an acute upper respiratory tract infection, it includes rhinosinusitis, pharyngitis, tonsillitis, and laryngitis. A variety of viruses and bacteria can cause upper respiratory infections, and defining these conditions individually is difficult because the presentations often overlap. But most upper respiratory infections are self-limited, and the viral infection causes irritation and swelling of the upper airways. Associated with this is a group of nasal symptoms and cough. Upper respiratory infection means there is no evidence of pneumonia. So in today's session, we are not going to be talking about any infection of the lower respiratory tract, and we are also not going to be covering the bacterial infections of the upper respiratory tract. Next slide, please. So, like Dr. Yagnesh has already said, URI is responsible for more than 20 million missed school days in the life of a child globally, and more than 20 million days of work days lost. So it is a huge economic burden. It is the commonest reason for outpatient visits. Majority of these visits result in needless antibiotic prescriptions. That is why we are having this session. The screen has gone blank.
Yeah, ma'am. The resharing. 1 second. Yeah.
Dr. KK, can you please check once again?
That's what, ma'am. They're resharing it. Updated one.
Yeah.
Stuti? Yeah, sorry for the technical issues there.
Yeah, so no, not an issue. I can continue to speak while the team is sharing the screen.
Yeah, it's up. Yes, ma'am.
Next slide, please. So adults may have 2 to 3 episodes of common cold in a year, but children can have up to 8 episodes in a year. And the peak in the incidence of upper respiratory infection is seen around this time in the fall and winter season. Next slide, please. The commonest cause of common cold is the rhinovirus. There are other viruses which can cause common cold as well as upper respiratory infections. Adenovirus, influenza, parainfluenza, RSV, enterovirus, and of course the coronavirus. Much of the interest in upper respiratory infections by viruses has been generated after the COVID pandemic. Do these viruses give immunity against subsequent infections? With rhinovirus, adenovirus, influenza virus, and enterovirus, there is lasting immunity after one episode. But this immunity does not prevent subsequent episodes of cold because there are hundreds of serotypes. And with RSV, parainfluenza, and coronavirus, there is no long-lasting immunity. So reinfection does occur, but usually these reinfections are milder and of shorter duration. Around 15% of upper respiratory infections are caused by bacteria. And the commonest of this is group A streptococcus causing a sudden onset pharyngitis. But as I said before, we are not discussing bacterial upper respiratory infections. Next slide, please. So the risk factors for an upper respiratory infection include close contact with children, both in the daycare and in schools, medical disorders like asthma, allergic rhinitis, and cystic fibrosis, immunocompromised state like HIV infection, use of corticosteroids, post-transplant and post-splenectomy states, anatomical anomalies like the cleft and craniofacial anomalies and nasal polyposis, and of course, smoking. Children don't smoke, but they cannot escape the effect of passive smoking. So often we have questions from parents asking, should I avoid daycare for my child because he or she is getting recurrent episodes of common cold? Even though young children in daycare do have more episodes of colds than those who are cared for at home, when this child is going to step out of the protected environment of the home into the school later, the child is going to have more episodes. So it really doesn't help in not sending a child to a daycare. Next slide, please. There are three mechanisms by which these viruses can spread. And after the pandemic, even lay people have become aware of these three transmission modes. One is hand contact, that is self-inoculation of one's own conjunctival mucosa, nasal mucosa, or oral mucosa by touching a person or an object contaminated with the cold virus. The second mode is inhalation of small particle droplets, which are airborne by sneezing or coughing from an infected patient. And the third is by deposition of large particle droplets, which are expelled during sneezing and coughing directly on the nasal or conjunctival mucosa. This, of course, requires close contact with an infected person. Young children, during the pandemic, they were labeled as super spreaders. Young children are often responsible for the transfer of infection within the home. They are more often the cause than adults. Next slide, please. So after deposition of the virus in the anterior nasal mucosa, replication starts. But most of the clinical features are due to the inflammatory response of the host. The inflammatory response of the host causes vasodilation and increased vascular permeability. These events cause nasal obstruction and rhinorrhea. The subsequent cholinergic stimulation prompts mucus production and sneezing. Symptoms may begin as early as 10 to 12 hours after inoculation of the virus, but the incubation period for most common cold viruses is 24 to 72 hours. Next, please. Most of us are very familiar with the symptoms of URTI. In infants, there is fever, nasal discharge, fussiness, and because of the blocked nose, there is difficulty in feeding, difficulty in sleeping, loss of appetite. In preschool and school-age children, there is nasal congestion, discharge, sneezing, feverigeness, and cough becomes a prominent symptom. In infants and young children, the symptoms peak on day 2 or day 3 of illness, but they gradually improve over the next 10 to 14 days. Though the cough may linger for 3 to 4 weeks, it must become better with time. It is important for us to know the natural course of this illness because we should also be able to pick up complications. In older children and adults, the symptoms usually resolve in 5 to 7 days. Fever may be present in the early phase of infection in young children. Older children, fever is not a very prominent clinical feature, but any new onset or recurrence of fever after the initial 3 days should give us an indicator that there may be a secondary bacterial infection. Next. So like I said before, in younger infants, the nasal manifestations are the most prominent. There is nasal congestion, discharge, and sneezing. On examination, the findings are unremarkable. There may be a little bit of erythema and swelling of the nasal mucosa. The nasal discharge is initially clear, but it often becomes colored within a few days. It may become yellow or green in color, but this color is because of the increase in the number or enzymatic activity of the polymorphonuclear cells. It does not, green or yellow color does not indicate bacterial superinfection or acute bacterial sinusitis. Acute bacterial sinusitis is indicated by persistence of nasal discharge for more than 10 days. without any improvement in the clinical symptoms or with worsening of symptoms. We will be talking about this under the session on complications. Next, please. In older children, cough is a more bothersome symptom. It occurs in more than 2/3 of children with common cold. That is what is most worrisome to the caregiver because coughing affects the child's sleep. It affects the child's school performance and ability to play. It disturbs the sleep of the household members. It may be disruptive in the classroom. It may linger on for an additional week. The symptoms of common cold in young children may last for 2 weeks, and cough may continue for another week or two after the other symptoms have resolved, but it should gradually improve. If the cough worsens or fails to improve with time, a diagnosis other than common cold has to be suspected. Next, please. So the diagnosis is a clinical diagnosis and viral testing is unnecessary. Lab testing can identify the viral pathogen when needed, like it became mandatory to test during the SARS-CoV pandemic. But other than that, in routine practice, there is no need to establish a viral diagnosis. If at all lab testing is required in young children and infants, we use nasal aspirates and swabs. For older children and adults, we take the aspirate or swab from the nasopharynx. The rapid strep test in throat swab can be used to rule out bacterial pharyngitis, and this can help to decrease the number of antibiotics being prescribed for viral upper respiratory infections. Next, please. Differential diagnosis. It's important to know what other conditions can cause similar nasal symptoms and cough. Allergic rhinitis. This is identified by the previous history, by the pattern of onset, and by the history of exposure. Acute bacterial sinusitis should be suspected when there is facial pain or persistent nasal discharge for more than 10 days or increased severity or worsening of the symptoms. Nasal foreign body can mimic an upper respiratory infection. So clues are a unilateral purulent or bloodstained nasal discharge, and anterior rhinoscopy can identify the foreign body once the purulent discharge has been aspirated. Structural abnormalities, cleft and craniofacial abnormalities, these children usually have persistent nasal congestion because the food that they take irritates the nasal mucosa, but cough and sore throat and fever are not seen. Pertussis is a bacterial infection of the upper respiratory tract. It begins with a mild cough and coryza that is called the catarrhal phase, but soon the cough increases and becomes paroxysmal and the characteristic whoop can be noted. Bronchitis is infection of the lower airways. It is caused mostly by viruses, but when wet cough lasts for more than 4 weeks, it could be a symptom of protracted bacterial bronchitis for which antibiotic treatment is indicated. Next, please. So when should you suspect an alternative diagnosis? The child is likely to not be having a common cold if there is a fever of more than 102.2 degrees Fahrenheit, particularly after the first 72 hours of symptom onset. Most children with viral upper respiratory infections are quite well looking in spite of the nose block. So any ill appearance should be a red flag. Absence of nasal symptoms is again an indicator of a diagnosis other than common cold. Wheezing and focal findings on lung examination indicate a lower respiratory involvement. Hemoptysis, a child who is underweight, has finger clubbing, has an overinflated chest, a chest deformity. All these are features of a chronic respiratory disorder. Next, please. So common cold need not be treated unless the symptoms bother the child or the other family members. Supportive care. I have to say here that the interventions in this slide, the efficacy of these has not been established by randomized controlled trials, but these interventions are commonly used. They are inexpensive and they are unlikely to be harmful. The first line interventions are nasal suction, nasal saline drops, nasal sprays or irrigation, adequate hydration. No, I think we have skipped one slide. Can you go back to the previous slide? Yes. So under supportive care, it's most important to maintain adequate hydration because adequate hydration helps to thin the secretions and soothe the respiratory mucosa. Ingestion of warm fluids has a soothing effect on the respiratory mucosa. It increases the flow of nasal mucus and loosens the secretions, making them easier to remove. Topical saline applied to the nasal cavity helps in removing the bothersome nasal secretions. It also helps in mucociliary clearance and leads to vasoconstriction and decongestion. Humidified air, many of us are used to recommending steam inhalation, but it has been shown that cool humidified air is better in loosening the nasal secretions. The World Health Organization, however, is suggesting neither steam nor cool mist therapy in the management of common cold. Next slide, please. Fever is treated with paracetamol, and in children older than 6 months, ibuprofen can also be used. Nasal obstruction interferes with drinking, and it is the most bothersome symptoms in young children. And if the first line interventions, which have already been described in the previous slide, do not work, you can try increasing the frequency with which these are administered. And if they still do not improve, for children less than 12 years, ipratropium nasal spray can be tried. In children older than 5 years. For children above 12 years of age, in addition to ipratropium nasal spray, oral and nasal decongestants can be tried. The nasal decongestants include oxymetazoline and xylometazoline, but these should be used only for 2 to 3 days because longer use may result in rebound nasal congestion after discontinuation. Oral decongestants, pseudoephedrine is preferred to phenylephrine. Next slide, please. Cough is actually a protective mechanism. The parents should be educated that coughing is actually helping the child clearing the secretions from the respiratory tract. So suppression of cough may result in retention of secretions and it may be potentially harmful. The airway irritation contributing to the cough can be relieved with good hydration, warm fluids, honey, or cough lozenges. The World Health Organization and the American Academy of Pediatrics are suggesting that honey is a potential treatment for URI in children above 2 years of age. Around 2.5 to 5 ml can be given either straight or diluted in warm fluids. The American Academy of Pediatrics is also suggesting cough lozenges to soothe the irritated throat for children older than 6 years. In younger than 6 years, because of the risk of aspiration, these are better avoided. The AAP has recommended against codeine and dextromethorphan containing medication for the treatment of cough. The World Health Organization also recommends against codeine, but has suggested that dextromethorphan can be used when there is severe prolonged cough interfering with sleeping or feeding. But it's always important to rule out other conditions and complications when the cough is severe or prolonged. Next, please. Regarding over-the-counter medications, I think there was also a question. Most of these over-the-counter medications, they contain antihistaminics, decongestants, antitussives, expectorants, mucolytics, antipyretics, analgesics, and a combination of these. Definitely, they should be avoided in children below 12 years of age, except for antipyretics and analgesics. In adolescents, children above 12 years of age, they do provide some symptomatic relief of the nasal symptoms. The reason we avoid over-the-counter medication for young children is because of the potential for toxicity. The metabolism, clearance, and drug effects may vary according to age, and the safe dose recommendations for young children has not yet been established. Next, please. Regarding other medications, definitely no role for antibiotics. Antibiotics cannot be given prophylactically to prevent secondary complications. They should not be used because they cause side effects and they contribute to antimicrobial resistance development. So they should be reserved for clearly diagnosed secondary bacterial infections like bacterial otitis media, sinusitis, or pneumonia. Regarding antihistaminics, in randomized controlled trials, neither antihistaminics nor combination of antihistamine decongestants has been effective in relieving symptoms. Because they may have adverse effects like sedation, paradoxical excitability, respiratory depression, and hallucinations, they are currently not recommended for the treatment of common cold. Regarding expectorants and mucolytics, guaifenesin alone is relatively safe, even though the efficacy has not been proven, but it is not available alone. It is usually available as a combination. So we are not recommending guaifenesin either. The adverse effects of mucolytics like acetylcysteine and bromhexine include bronchospasm, GI disturbance, and fever. Bronchodilators in children with asthma who develop a cold, because viral upper respiratory infection is a common trigger for asthma exacerbation, bronchodilators rescue medication should be used according to their asthma action plan. Aromatic vapors are very popular among families. They contain menthol, camphor, eucalyptus oil. They increase the perception of nasal patency, even though it is not objectively proven. And they also, caregiver reported reduced severity of cough and improved sleep. Next slide. Prevention, the most important aspect of prevention is hygiene, frequent hand washing, avoiding touching one's nose, mouth, and eyes, coughing into a tissue or the crook of the hand, disposing the tissue in a waste paper bin. Decontamination of surfaces with virucidal disinfectants such as phenol and alcohol may also help in preventing transmission. And very important is influenza immunization for all individuals above 6 months of age and COVID vaccination according to the national policy. Several other, because of the economic burden caused by common cold, several other medication have been tried in RCTs, vitamin D, but neither daily nor monthly administration of vitamin D has reduced either the incidence or the severity of common cold. Vitamin C also, in a meta-analysis of 14 trials, an intake of 200 grams per day of daily vitamin C was shown to shorten the duration of common cold by 14% without any serious adverse effects. A lot of interest was generated by zinc, but RCTs indicate that oral zinc may help in preventing common cold and decreasing the cold duration and severity. But the benefits are limited because of the need for prolonged daily administration, almost for more than 5 months. And the adverse effects of zinc are well known. The taste is bad and it causes nausea. So currently, we are not recommending vitamin D, C, or zinc for the prevention of cold. The focus is on hygiene and immunization. Next, please. The complications of common cold, because common cold is so common, we also have to be aware of the complications which can occur after common cold. Acute otitis media in the 1/3 to half of children of colds in young children, there is inflammation of the tympanic membrane and fluid in the middle ear. But bacterial or suppurative otitis media occurs in 15 to 19% of colds in children, and the risk is maximum in children between 6 months to 1 year of age. The presence of a suppurative otitis media is indicated by a new onset of fever and earache. Asthma exacerbations occur in susceptible children, and at least 50% of exacerbations in children is triggered by a viral upper respiratory infection. Sinusitis occurs in 6 to 13% of viral URIs in children. The presence of a bacterial sinusitis is indicated by persistent nasal symptoms without improvement for more than 10 days, by severe symptoms with high fever, ill-appearing child, purulent nasal discharge, and worsening of symptoms. Lower respiratory tract infections like bacterial pneumonia are indicated by new onset fever and increasing cough. And the complications related to SARS-CoV-2 are well known, multisystem inflammatory syndrome in children. Next, please. Influenza can affect the upper respiratory tract or the lower respiratory tract. The presentation of influenza varies with age and previous infection. Generally, it is a self-limited infection in healthy children, but it can be associated with severe morbidity and mortality. Most influenzas are caused by the type A or the type B influenza virus, but in young children, type C is also a cause. The influenza A virus is classified into subtypes according to the surface antigens hemagglutinin and neuraminidase. We have H1N1, H3N2, depending upon which of these antigens are present in the virus. So influenza occurs as distinct outbreaks every year, mainly in winter, but the specific timing and duration of the flu season varies from country to country and from year to year. The epidemiological pattern reflects the changes in the hemagglutinin and neuraminidase surface antigen. This is also referred to as antigenic shifts and antigenic drifts. Next, please. Next, please. So the attack rate varies between 10 to 40% in a typical flu season, but all these attacks are not symptomatic. Symptomatic influenza in children below 18 years approximately occurs in 9% of the population. The hospitalization rate is highest for infants less than 6 months of age. And among those hospitalized, around 20% need ICU care and 5% need ventilation. And the mortality is 0.5% among the hospitalized children. The factors that are associated with increased mortality include underlying medical conditions such as congenital heart diseases, chronic respiratory conditions. In children below 5 years of age, particularly those below 2 years and among those below 6 months of age, bacterial co-infection and increased circulation of H3N2 strain. Next, please. The classical clinical features are an abrupt onset of fever with headache and malaise, with upper respiratory symptoms, cough, coryza, and rhinitis. But these classical features may be absent in young children, particularly because they may not be able to vocalize their upper respiratory symptoms. These children may present with just high fever without a focus. They may present as febrile seizures, and the respiratory findings are less prominent. GI findings are more prominent: nausea, vomiting, diarrhea, and poor appetite. These children may also have conjunctival erythema, nasal injection, nasal edema, eye discharge, cervical lymphadenopathy, and parotitis. The spectrum of clinical findings and the severity vary depending upon the type or subtype of influenza. Symptoms are definitely less severe in children who develop the infection after getting the vaccine. Next. Next, please. Next, please. The complications of influenza are similar to those of common cold. We are particularly worried about bacterial co-infection. Staph aureus and strep pneumonia are notorious for causing bacterial complications after an episode of influenza. So bacterial co-infection should be suspected in those children who have clinical deterioration after initial improvement, or those children who fail to improve in 3 to 5 days, or if there is an abrupt recurrence of fever after 1 or 2 weeks of recovery. The other complications include an exacerbation of asthma and laryngotracheal bronchitis. In immunocompromised children, you can have invasive pulmonary aspergillosis as a complication of pneumonia. Bacterial infections can also occur in other parts of the body, like in the head and neck, orbital cellulitis, retropharyngeal abscess, and peritonsillar abscess. Next, please. There are complications related to the central nervous system in approximately 10% of children hospitalized with flu-like illness. These include febrile seizures, encephalopathy, non-febrile seizures, encephalitis, aseptic meningitis, bacterial meningitis, cerebral infarction, and Ray's syndrome. There are other rare complications of influenza, such as cerebellar ataxia, transverse myelitis, Guillain-Barré syndrome, and acute disseminated encephalomyelitis. Musculoskeletal complications are rare but severe. It usually affects the calf muscles. CPK is elevated, and there may be associated myoglobinuria. Next, please. So there are many viruses which cause a similar clinical syndrome. The respiratory syncytial virus, SARS-CoV, parainfluenza. It is not possible to clinically differentiate between influenza and the other respiratory viruses. So this clinical syndrome is called influenza-like illness. Laboratory confirmation is not necessary for initiation of antiviral therapy, and the supportive care does not differ. Laboratory confirmation is done by detection of the viral protein or the viral.
Hello.
It seems you must have lost the
Yeah,
connection.
lost. Yeah.
Should I stop sharing as of now?
No. Krishna Kumar, can you call her?
Yeah, I'll do that. Yeah.
Krishna, how many slides are left? I think Dr. Padmini, she's back.
Yeah.
You can see her movements here. She's speaking. Dr. Padmini is Padmasini, you are muted. Please unmute yourself.
Yes, I'm so sorry. My connection broke. I have just 2 more slides, I think.
Yeah.
Next,
Sure,
please.
Yeah.
So the Indian Academy of Pediatrics has given very clear guidelines on the management of influenza. Category A refers to those who have mild fever with cough and sore throat. These children require only symptomatic treatment with fluids and paracetamol. They should be asked to confine themselves to their homes and not mix with public or with high-risk members of the family. There is no need for antiviral drugs or retest or viral testing. They should be reassessed with close monitoring, and the caregiver should be educated to watch out for red flags. Next slide. Category B is those who have these symptoms and in addition high-grade fever and sore throat, and those children who have a pre-existing chronic illness. In these children, oseltamivir should be started as soon as the diagnosis is suspected, preferably within 48 hours. Next slide, please. Category C refers to children who, in addition to these symptoms, have breathlessness, chest pain, drowsiness, hypotension, blood in the sputum, or any other manifestation of severe disease. These children require immediate hospitalization, treatment, and should also be tested. Next slide, please. Next. Among the antiviral drugs, there are 2 groups, but we no longer use amantadine because it has no effect on type B influenza, and after 2009, all the strains of influenza A are also resistant. So currently we are using only neuraminidase inhibitor enzymes, that is oseltamivir. Oseltamivir has been recommended for use in children above 3 months of age. The dose is according to the body weight. For those above 13 years, we give 75 milligram orally twice a day. The maximum dose is 300 milligrams per day. The next slide. Prevention, we have already discussed prevention of common cold. The same changes are, behavior changes are useful in preventing influenza as well. In addition to that, it is recommended that vaccination be given to children above 6 months of age, particularly those between 6 months and 5 years of age. There are 2 vaccines available. The quadrivalent vaccine is recommended. Children below 6 months to 8 years should receive 2 doses 1 month apart. For those above 9 years, a single dose is adequate. The annual revaccination is with a single dose. The next slide, please. Chemoprophylaxis is not routinely recommended because it is it is useful in reducing the symptomatic influenza among contacts, but there are other ways, there are other alternatives such as immunization of susceptible children, their household contacts, and their caregivers, and early treatment of exposed individuals, and behavioral interventions to limit the spread of influenza. We do not recommend chemotherapy because it promotes development of resistance to antiviral medication. Most importantly, in an outbreak, it reduces the availability of medications for the severely ill people, and also because of the side effects. Next slide, please. So to summarize, URIs are usually mild and self-limiting, and caregiver education is the mainstay of treatment. Complications should be identified and treated appropriately. Over-the-counter cough and cold medication should be avoided in children below 12 years because they have no proven benefit and they may have serious adverse effects. Children with common cold need not be excluded from childcare or school because by the time they manifest the symptom, they would have already spread the virus. The risk of spread can be decreased through hand washing and cough hygiene. And children with cold symptoms who are known to or suspected to have SARS-CoV infection should be isolated according to the local guidelines. Thank you very much once again for the opportunity. I'm happy to take questions.
Thank you, Dr. Padmasani. It was an excellent presentation. You had, in a nutshell, covered almost all topics of the related to the viral URI. One thing only I would like to stress is with regards to the diagnosis. The only major requirement with regards to the diagnosis of viral URI requirement is a confidence of a clinician in his clinical acumen, so that he do not leave the child for the laboratory to undergo the multiple tests, as well as the do not prescribe multiple antibiotics. The confidence is the primary requirement of the diagnosis.
Absolutely. Yes, sir.
There are few questions in the chat. Krishna, do we have a time? Can we go for at least one or two questions?
Another 2 minutes we can take it.
Yeah, okay. 1 or 2 questions only. One of the question is with regards to the over-counter medicine. We strictly say no to it. Do we have any other comment from the Dr. Padmasan with regards to the OTC products?
So for children below 12 years of age, it is strictly no. They are not of any benefit. They are harmful. For children above 12 years of age, they can be given. They do provide some symptomatic relief. It has to be individualized.
Okay, fine. And one more question with regards to the changing behavior of the viruses. After the COVID, we had seen the many of the viruses which were not causing the issues initially, but now they are. For example, adenovirus, which was there was an epidemic of adenovirus with different clinical presentation as well as the laboratory presentations. So, do we have your comments on that?
Yes, sir. It is a pattern that we have all seen. It could be that we are more vigilant now. Now we are recognizing the viral etiology more often now. But it is also true that adenovirus especially and several other viruses have also changed their behavior, perhaps through mutations. And many of them are causing clinical syndromes which have not been seen, wider spectrum of clinical features and more severity.
Yeah.
It is a very dynamic situation and it is expected to happen.
Yeah, thank you, Dr. Padmasani, for an excellent presentation and nice discussion. Over to Dr. Krishna for further proceedings.
Thank you, Ignesh, sir, for chairing this session, and thank you, Dr. Padmasani, ma'am. Thank you for the wonderful session there on the viral URI there. Moving on to the next session, we have Dr. Sukumaran sir joining in today. So Dr. Sukumaran will be the chair for our next session, and Dr. Ravishankar Marpalli is the speaker. Dr. Sukumaran sir does not require any introduction, but as a formality, I would like to introduce the audience. He is the former professor and head of Department of Pediatrics at KIMS Tiruvalla. He's also been the past IAP president in 2011. He's also one of the core member of the Fever Foundation, who has been instrumental in activities, especially the quiz and the poster activities for the PG students. Thank you very much thank you for all your support, and thanks for all your support. That's why we are here at the 6th annual national conference of FEFCON. And it's over to you to take over the session. Also, at the same time, I also would like to welcome Dr. Rashna ma'am joining in. She is also the member of the Fever Foundation. Thank you, ma'am. Thank you for joining in. Sukumaran sir, it's yours. Thank you.
Okay, Krishnamar, am I audible?
Yes, sir. Yes,
okay. Sir. Okay. Good evening, everybody. Beloved friends, it gives me great pleasure and privilege to be here with you to participate in this CME program, FEFCON, organized by Microlabs. And I should congratulate the Microlab, all the organizers for organizing such a wonderful CME program. And this talk is on a very common problem, that is viral exanthem. I am very happy to chair this session because Dr. J.V. Shankara is a very close friend of mine, a very close associate of mine. I'm very happy to chair this session, and he will be talking mainly on viral exanthem. We see a lot of viral exanthems starting from exanthematous fevers 1 to 6 are there, and a lot of other viruses are there. And now we are facing an outbreak of measles. Even in Kerala, we see measles in early infancy. 1 month, 2 months children presenting with measles, and also a lot of children are coming with hand, foot, mouth disease. Even though hand, foot, mouth disease is a minor illness, sometimes it can produce ARDS, pneumonia, encephalomyelitis, and Guillain-Barré syndrome, etc. So it's not a simple disease, and it is our duty to protect our children from measles by giving early MMR vaccine. With this words, I like to invite Dr. Ravi Shankara, who is a senior consultant and HOD of Pediatrics SS Marsh Hospital in Bangalore. He was the president of IAP BPS 2020. He is the president of IAP ID Karnataka chapter 2021 and vice president of IAP Neurology. And also he is the EB member of IAP Neurology chapter, and he was the election commissioner of Indian Academy of Pediatrics from South Zone. With these words, I have great pleasure to introduce Dr. Ravi Shankara, and I invite Dr. Ravi Shankar to start his talk on common exodermal diseases. Dr. Ravi Shankar, please.
Thank you, Sukumaran. I missed one sentence in your slide. That is, you are the Bhishma of IAP Kerala, and innumerable contribution to the central IAP. Thank you, sir. And at the outset, let me thank the Fever Foundation, led by Dr. Jagdish Chinnappa and others, for giving me this opportunity to speak on the fever with rash. At the beginning, let me confess, it is a huge topic. So whatever the things I saw in my clinics in last few years, that I have shared it, and as it is taken with the mobile, some photos may not be there. That's the reason I had downloaded few things from the website where it is allowed to share the things. So that is the confession I'm doing at the onset itself. So fever with rash, it is a very interesting thing. Almost we can hours together we can speak on that one. So let me start with a case. This Rukmini, age 14 years, admitted with history of fever, burning micturition, chills and dry gulp, loss of appetite 3 days. Urine routine showed plenty of pus cells, bacteria seen, RBCs numerous, culture grown Klebsiella pneumoniae, and resistance to all except amikacin and Septron. Started on IV amikacin. This is the second episode she had it, and referred to us at the second episode. And something I felt something fishy about this case. Why within a few weeks she's getting that one, and some weakness and other things were there in that one. So what made me to have some more doubt is this rash, of course, not come out well. If you're able to see that one, there is something. So on the second day after the admission, I saw it first day, but I didn't give a much concern about it. Second day, it was still more apparent. So I asked the mother what exactly it is. She told side is there since last 3 years, comes and goes. When she's exposed to the sunlight, it increases. And meanwhile, she had passing plates of blood clots now and then in the urine that was there. That gave me a little clue, something I'm dealing with some other thing. So when I did an ANA screening, it came positive, Coombs test direct positive, C3 level low, and kidney biopsy revealed lupus nephritis. Now she's on treatment for SLE, and she is doing better. So this is a downloaded thing where you can see a malar rash, which is almost called as a butterfly rash. We can see the nasolabial fold, and it won't extend to the just above the nasolabial fold. It will be there. That is the way it can differentiate with dermatomyositis. There also will have a rash on the face. So this is the one. So that gave the clue to us. So that's the reason rashes are sometimes a window to us to think of something different when we are not able to do clinically some diagnosis like that one. So at the same time, rashes are also a difficult paradigm to us to do what exactly do the things. It may lead to some confusions also. Reason being, the skin manifestation may be due to the systemic manifestation, and systemic manifestation in turn lead to the skin manifestation, because skin is associated lymphoid tissue. Whatever it is part and parcel of both the innate and the acquired immunity. So it also has got the macrophages, Langerhans cells and everything. So whenever the skin gets infected, it will react. At the same time, whatever the infection is there inside the body, to the blood vessels in the dermis, it comes there. If at all there are which can provoke the skin tissue there, it will lead to the skin manifestation. So which one will lead to the provoking of the skin cells or the macrophages which are there in the dermis and epidermis? they will lead to the rashes. Not all the things, because whenever there is a dissemination in the blood vessel, everything will go to the skin also. But all the fevers will not give rise to the rashes. Some will give to the rashes. That is because they are going to provoke the cells which are there in the skin. So skin is the body of the body defense system, and it is both an entry point and exit point. So some of the infection can enter through that one, because whenever there is a bite, insect bite, tick bite, mosquito bite, everything, it will enter through that through the skin only. And also an exit point, like for example in varicella or chicken or in monkey pox, like that one, where the vesicles which are there that contain, or in the hand foot mouth disease, it contains the vesicle which the secretion contains the viruses. It will, when you touch it, you can get the infection, or through inhalation also you get the infection. So this is one classical example of larva migrant, whereas enter through the feet, and the larva is migrating through that one and causing this beautiful picture. Looks very beautiful, but it is horrible to the patient who is suffering there. So the crust, I already told, crust of the many exanthaviruses, varicella, monkeypox, leprosy are infective and spread to the other organ. And at the same time, rheumatic fever and glomerulonephritis, post-structural glomerulonephritis, they're all due to the primary bacterial infection that is causing this infections in the body. So there are 4 ways the skin may be affected. It may be a direct involvement by the infectious agent. It may be a specific reaction to an infection, or it may be a non-specific reaction to an infection. In addition, there are number of inflammatory dermatoses that can mimic skin infection. When it is a direct involvement, we know it is a direct inflammatory reaction that is occurring, or it is a specific reaction, whatever the antigen it contains, the body is reacting to that one. Or a non-specific reaction, because we have got so many hypersensitive reaction, type 1, type 2, type 3, type 4. So when something goes to the skin, it will be a non-specific reaction to infection. We cannot identify which infection is causing. That is the meaning there. So pathophysiology is that one. We know the systemic infection may be recognized by the characteristic skin lesion. That is a very, very important thing. Some of the rashes will give us the clue, like measles, rubella, varicella. There is a temporal or a chronological development will be there. The rashes developing on the 3rd day, 4th day, 1st day, we know, and how the rashes develop. It is ascending type, descending type, or it is a centripetal, centrifugal. By that time, we can diagnose a clinically these infection. The best examples are measles, rubella, varicella, and monkeypox. We can almost clinically diagnose them. Otherwise, it could be a bacterial emboli, as in a case of infective endocarditis, where the Janway disease, Janway marker, Osler's node, splinter hemorrhage, all these things are nothing but a bacterial emboli. Or it could be a vasculitis, or could be due to intravascular coagulation toxins, the purpura fulminans, eczema gangrenosum, disseminated candidermia, and toxic shock syndrome. So these are the examples for these bacterial emboli, vasculitis, and intravascular coagulation, like that one. So whatever the disease, the skin has a perfect lesions. So these lesions will be there. So we have to diagnose the thing by, as I told, when it is going to develop, and what is the ascending type, descending type, centrifugal, centripetal type, we are going to diagnose the thing. But the lesions are the same. It is a macule. A macule is nothing but a lasting local dilatation of the subpapillary dermal blood vessel. That produces the macule. Whenever the edema collects there, that becomes a papule which comes above the skin. That is a papule. Or when there is a separation of the epidermis from the dermis and fluid collects there, that causes the vesicles. And there is a polymorphic nuclear cell implantation there, that causes the pustule. So these are the skin rashes that we are going to see in whatever the reaction we are going to get it. Then the ulcer, when whatever the sloughing occurs, that causes the ulcer, or it could be without scab formation, or when a hemorrhage occurs, it could be a petechial or hemorrhagic rashes. It could be there. So these are the classic skin rashes that we are going to get in any type of lesion, and we are going to identify them by the lesion type, whether macules or papules. That is called primary morphology. or lesion configuration, whether they're linear, annular, or hypertogenous, that is called secondary morphology. And the texture, lichenification is there, induration is there, or umbilicated, that is the texture, and the local and distribution, which I already told, and the color of that one. So these are the way we are going to identify the rashes. And there are few signs out there which give us few clues, like diarrhea sign. Diarrhea sign is nothing but a rapid swelling of a lesion when it is stroke, as is seen in a case of urticaria pigmentosa or mastocytosis, or Nikolsky's sign when epidermal shearing that occurs with gentle lateral pressure. When you apply gentle lateral pressure, that leads to separation of that one. That is seen classically in toxic epidermal necrolysis or bullous diseases, or aspid sign when the appearance of pinpoint bleeding after scale is removed from the plaque, that is classically seen in psoriasis, or Koebner phenomenon where with development of the lesion within areas of the trauma when you stroke there, that is called Koebner phenomenon. These are a few signs that give us some clues about the diagnosis. So now let us go into the whatever the description I gave initially. There is a direct involvement of the skin by an infectious agent during a systemic infection. Is that the skin is also involved along with the systemic infection. The best examples are varicella, hyperfembrine, monkeypox, or bacterial infection like gonococcal, TB, Lyme disease, syphilis, yaws, pinta, or fungal infection could be there. So let us discuss few diseases. Varicella, we know the chickenpox, how it comes. Is a fever of 1 day and vesicular rashes develop within 24 hours. They are pleuritic and appears in successive. It is called polymorphic. But it means all type of lesions you'll see. You'll see maculotype, you'll see the papules, you'll see vesicles. So all these will be there. That's called polymorphia, and it comes in the centripetal, more in the truncal area it is common. Whereas the old and the smallpox, which you are not seeing it, it becomes the centrifugal. So this is centripetal type. When we see these rashes developing on the first day of fever, probably you'll think of a varicella in that case. This is the neonatal varicella that commonly we are seeing nowadays, and lot of questions in the WhatsApp also. So what exactly here it is, whenever the mother develops the varicella around the time of delivery, she doesn't have any immunity at all. So she does not pass any antibodies to the baby, but she will pass the viruses to the baby. So the baby does not have any passive immunization at all. So it becomes a very serious disease, both to the mother and both to the child. So if you think an incubation period of 10 to 23 days, so any lesion occurring before the 13th day of delivery, that is a serious disease. It has to be dealt very seriously. We have to give a passive immunization like with IVIG or varicella zoster immunoglobulin, and we have to give the antiviral drug like acyclovir also we have to give it. Anything beyond 13 days or 14th day, you need not bother much. That is the impression here. And as already told by Dr. Sukumaran sir, we are also seeing measles in other areas of Karnataka also, in other parts of the India also we are seeing. So whenever you see a fever of 2 days, 3 days of fever, please look into the mouth. What you can see above the first molar, you can see this something called as Koplik spots, which is nothing but a white tip surrounded by a red area. So if you see that one, that you are dealing with a case of a measles. So be careful. So you may get infected and avoid take other preventive measures and tell to the parents baby may be developing the measles. So Koplik spots. This is nothing but a venous dilatation around the submandibular lacrimal duct. And on the fourth day of fever, you will see the erythematous, maculopapular, blanching rashes in the ascending type. So they develop just behind the ear, face, then goes to the neck and to the other parts of the thing. If you see such evolution of your rashes, then you are dealing with your measles along with the Koplik spots. Then coming the hand, foot, mouth disease, we are classically seeing since last few years. So there are two types here. There is a classical or typical or atypical. Typical means there is a Coxsackie virus, the A16 or enterovirus A17 they are causing. As the name suggests, you will develop the palm, foot and the mouth, and around the buttock you will see. When you see that one, then not much variation is there. A macular lesion later progressing to the vesicles, and surrounded by an erythematous halo, then you probably are seeing a typical case, that one. Initially, we thought hand-foot mouth disease is benign, not much problem at all. But there are a lot of studies done, and in fact, a study done by my good friend Dr. Vikram Kumar. He has produced a paper. So, hand-foot mouth disease produced by the enterovirus 17 is not benign. It could be, it is not harmless. It can lead to some of these complications like polio-like syndrome, aseptic meningitis, encephalitis, encephalomyelitis, so many. Neural involvement is more common, and also there could be a myocarditis. They have seen a lot of cases of these cases in Shumaga, in and around Shumaga, and also we have got a lot of papers also, that one. So that's the reason whenever the mother comes, please, whenever the parents come, please don't assure them it is very benign. As of now, it is benign, but you have to wait and watch. So there's something called as an atypical hand-foot mouth disease that is due to the Coxsackie virus due to 6 that is causing that one. What exactly here it is, whatever the lesion, they may not be exactly at the hand-foot mouth disease as rightly told. It could be around the joints, and the lesions will be more severe, more blister-like around the joint, around on the face, like that it could be there. And something called as, which are commonly asked in the WhatsApp, everything in the academic groups, something we have seen, something like that. It is called, it is nothing but onychomedesis. There is shedding of the nail. It comes about a few days later after the HFMD, and shedding of the nail and this white nail, horizontal lesions, white patches, you can see that one. So that is called onychomedesis. Nothing can be done. It is harmless, and just wait and watch. Just assure the parents. Then after that, we'll go to the specific skin reaction resulting from systemic infection. Here it is the skin reaction can establish the diagnosis of the specific systemic infection, and it is thus very important to recognize them. Like a virus or Rhesiola infantum, slapped cheek appearance, we see very commonly that one. So when you see that, that is called fifth disease. When you see that one, probably you can tell it is harmless, that one. Then the scarlet fever, then staphylococcal skin syndrome, then toxic shock syndrome, leprosy, and the rheumatic fever, then eczema gangrionism. These are specific skin reaction, okay, due to the systemic infection. So few things let us discuss. Scarlet fever, initially we thought it is not there in India, but a lot of cases has been seen by my good teacher, Dr. Bhaskar Shane, Dr. Dextinappa, and everybody like that one. So what exactly here you see the same thing like a slapped skin appearance, and the rashes which are appearing, red blotches are the first sign of the rash after the 12 to 48 hours of fever, and sandpaper like maculopapular region first appearing on the trunk and extending later to the ear, neck, elbow, and inner thighs. So, but this is the thing we have to keep it in mind. And if you see the throat, you will have the strawberry tongue, you will see, then we have to think of a scarlet fever, because this is the one which requires an antibiotic. Then coming to the staphylococcal scarlet skin syndrome. So the very irritable child fever, within 24 to 48 hours, a very tender rash develops, initially around the face, as you see here, and the flexures, that is groin, axilla, neck, with erythema and fissure. Later, large thin blisters will be there, and the characteristic flaccid blisters and bullae contain thin, sterile cloudy fluid, and frank yellow pus will be there, as you rightly can see it here. What exactly it is, you have to differentiate it from scarlet fever, toxic shock syndrome, and toxic epidermal necrolysis by one differentiating thing, that one. So there is no mucosal involvement in the staphylococcal skin syndrome. That is the one differentiating skin. Otherwise, it almost mimic like that one. And here it requires an antibiotic, whereas in scarlet fever also requires an antibiotic. But other things, the antibiotic may be contraindicated because antibiotic itself might have caused the thing, that one. So that's then you have to be little careful about these things. Then coming to the eczema gangrionism, there is very few cases we have seen, and of course rare disease. I'm not telling it is very common. What it is common in the neonatal age group, less than 2 months also. So erythematous or purple macules initially develop on extremities or the anogenital region and become bullous and hemorrhagic and rupture to leave a gangrenous ulcer. You can see the gangrenous ulcer here with central black shard will be there. This is due to the Pseudomonas aeruginosa. So that is the reason it is an immunocompromised child, more or less. So that reason we have to recognize it early and treat it with appropriate antibiotic. You cannot neglect here. Then we'll go to the non-specific cutaneous signs of systemic infection. So it means these erythema multiforme and those things, they're non-specific. That means it won't tell a particular disease at all. It could be seen in most of the diseases. And so when you see that one, you have to see something is there in that one. So erythema multiforme. So initially it was commonly seen with herpes simplex infection, but now it is seen in mycoplasma and other so many other viruses and bacteria. The next slide I will show you. Here it is in a CD8 plus T lymphocytes in the epidermis that causes an apoptosis type reaction. So nowadays the cytokine storm after the post-COVID, we are most aware of this immune system. So that in the skin and also we are coming out of these things. So it is due to an apoptotic lesion due to the CD8 T lymphocytes. Okay, and more common with the individual person HLA-B12. So that is in all infection because many patients we have seen mycoplasma and herpes simplex. In them we won't see it. Those are with having then HLA-B12, it is 3 times more common. And these are the common other viruses and bacteria. Remember, the same slide is almost repeated in other things also. It is not that we restricted one particular thing. Initially, when they thought of, it was seen in few things. Now we are seeing in almost most of these viruses and bacterial and fungal. And even in the vaccines also, post-vaccine also, we are seeing that one. So it is nothing but erythema multiforme, nothing but a target lesion. When you see a target lesion, this is one of the things. And there could be a conjunctival involvement like burning eyes will be there, photophobia will be there, visual impairment, or genital lesion which are painful. And there could be urinary retention and painful micturition because genital urinary tract involvement and shortness of breath also will be there. So this is the one that we have to keep in mind when these are the other symptoms will be there. Then coming to next is erythema nodosum. Initially, we thought it is more common with TB and streptococci and that one. It is due to a type 4 delayed hypersensitivity reaction. Here is the difference is that it involves the subcutaneous tissue also. Something called as subtle paniculitis will be there. So it will be a mild fever, myalgia, and very painful. The main thing is when they touch it, they are very tender. So during our examination time, as a student, we used to touch it. All of us used to come and patient used to cry. So I remember that during our PG days, like for the TB, that one. So that's the reason, be careful about that one. Requires a good painkiller. And these are the same slide I told you, most of the time it will be repeated, almost all the same bacteria, viral, fungal will be seen in these things. Then coming to the cutaneous vasculitis, the common thing, it is due to type 3 hypersensitivity reaction, where an antibody-mediated complement-induced things will be there. Something like an acute leukocytoclastic vasculitis will be there. Complement fixation that occurs. So it is common. The clinical signs are a purpuric macular or papillary eruption on the lower legs and dependent areas and become bullous and later they ulcerate. So the same slides almost it is repeating. Then coming to the zoonotic crusty syndrome, very commonly asked in the WhatsApp academic groups. This is nothing but a delayed type of hypersensitivity response and it will be allergic. Little because atopy will be there, little allergic, itching will be there. After the episode of fever like that, and few days later, you will get these papilla, something like a papillar urticaria lesion, which will be there, which occurs, it involves the cheeks, buttocks, extensor surface of forearms, extensor surface of the legs will be there. So duration of the things almost can last up to 7 to 10 days. Doesn't require anything except for an antihistamines orally and some skin a local application will be there. So etiology, same thing will be there. So coming to the next is the Kawasaki disease. Now we know it is an acute IgA vasculitis affecting the medial size arteries. So already we know most of these things, strawberry skin, then scale, the tips of the fingers will be there. And the rashes will be there on the hands. These are the things. And the BCG, reactivation of the BCG site will be there. And anorectal skin rashes will be there. So this is another point we had to look into that one. The common denominator here is the interleukin 1 beta that will be there in the cells and even in the coronary arteries and tumor necrosis factor. That is a common thing they are getting everywhere when they have done the postpartum examination. So that is causing all these reactions. Then we'll go to the next slide, inflammatory dermatitis mimicking like an infection. So something like acute febrile neutrophilic dermatitis, like sweet syndrome. nowadays we are seeing a lot of inflammatory disorders. So same thing here also in the skin also we can see that one. It is activation of the specific pro-inflammatory signaling pathways, including TNF-alpha, interleukin-1, same thing like inflammatory disorder we are seeing commonly nowadays. So fever and leukocytosis will be there, and involvement of the eyes, musculoskeletal system, and internal organs also will be there. So there will be abrupt appearance of painful edematous and erythematous papules, plaques, or nodules on the skin will be there. Drugs and infection also give rise to that one. Common or streptococcal, salmonella also are there, and even vaccination also can give rise to that one. Something like a erythema multiforme like that one, it will be there. That we have to keep it in mind. Okay, so it may respond to the corticosteroid therapy, whereas in real erythema multiforme, it may not require a corticosteroid therapy. So these are the DDs we have to keep it in mind. There will be elevated ESR, neutrophilia will be there, as already I told. So we have to keep these things in mind. Then coming to the toxic epidermal necrolysis, nothing but an all-fast or a granulosine mediated apoptotic pathomechanism will be there. This is classically called as STEN, and there will be a widespread cutaneous erythema, sloughing will be there, epidermis in sheets will be there. The DD will be SSS, as already I told like that one. And there will be anatomate, that is because membranes also will be involved in this case, and something like that it will be there. Okay, bullets will be there, non-steroidal anti-inflammatory drugs. These are the common things that will be affected, and identification of presence or absence of microorganisms are important. I mean, little short of time is there. That's why I'm going through fast. Sorry for the thing. So these are the things will be there. So treatment outcome is improved by internal nursing in a specialized bunt unit and by prompt withdrawal of all potential precipitants. No specific treatment has been unequivocally proven to be effective. However, sometimes an intravenous immunoglobulin and plasmapheresis may be helpful in such cases. Then something called Wells syndrome is nothing but local hypersensitivity reaction. Occur only locally. Lot of itching will be there. So due to infection, arthropod bite, medication, immunization, hematological disorders, malignancies will be there. Here, nothing but an eosinophilic cellulitis. So if you do a blood picture, CBC, lot of eosinophilia, you will see that one. The picture, something will be there. And the clinical appearance is variable. Lesions can be single or multiple. The face and trunk may be affected. So it is a plaque-like, annular granuloma-like, urticaria-like, papillovesicular type, bullous type, papinodular type, fixed drug eruptions, like so many things will be there. So a little bit confusing, I know that one, but some clinical blood picture, I mean, blood investigation may be helpful. Lot of eosinophilia there, probably we can think of that one. Reason being, it if you do a skin biopsy, you'll see the flame figure, the classical one you will be see there. So it responds to the oral corticosteroid therapy. That is important. That reason probably you have to differentiate from other things. So probably I'm coming to the end of my presentation. There will be peripheral eosinophilia will be there, and skin biopsy need not be required every time. So we had to differentiate between bacterial cellulitis, erysipelas, parasitic infection, eosinophilic granulomatosis, and arthropod bite will be there. And sometimes it may require topical corticosteroid, cyclosporin, dapsone, methotrexate, that we have to keep it in mind. So, I mean, coming to the end of my presentation, this is the in nutshell, a brief outlook of the whatever the things told that one. It could be a direct involvement. Some may require a antiviral or antibacterial treatment. Some may not require anything. Some may require steroids. So we had to go through according to the clinical manifestations and the laboratory investigation. Thank you a lot.
Thank you, Dr. Ravishankar, for excellent presentation of this topic. So even though it's a very vast topic, you have highlighted the most important points, especially you have highlighted the importance of viral infections, especially the measles and hand, foot, mouth disease that we see now. And also you have touched upon the other autoimmune disorders, collagen muscular disorders, and all these disorders you have touched upon. Thank you very much for your excellent presentation. Is there a time for discussion, Krishna Kumar?
Yes, sir. We have a couple of minutes we can take in, sir.
Okay. There are a few questions on dengue. I think these questions we will not take up.
That is my post for the previous this one. Not
Okay.
not to me.
Okay. Mr. Kumar, can you show the questions?
Any questions are there?
So right now I'm waiting for the mailbox. Maybe we can go with the next session, sir. I think since we are running short of time, we'll go back to Ravi Shankar sir for the questions. Then we can take the mail things and we can send it back to the audience.
Okay. So once again, Dr. Krishnamma, thank you very much. And Jagadish Chinappi also, thank you. All the organizers for giving this opportunity to share this session. And congratulations for Ravi Shankar for the excellent presentation. Thank you very much.
Thank you, Sukumaran sir, and thank you, Ravi Shankar sir. As always, as evergreen, your presentation was too much to observe. Actually, I'm getting multiple accolades on the platform, sir. The presentation, the pictures, and the correlation are fantastic. Sir, and there are many requests that they need your slides. Okay, sir. Thank you, sir. Thank you very much. Yes, sir. Thank you, sir. And I think we'll move on to the next session. It's a panel discussion, and we hand over session to Dr. Rashna ma'am. Dr. Rashna ma'am, she's also the quiz master of the Fever Foundation team. She has been recently we concluded the zonal as well as the national level PG quiz competition and also the poster competition. She has been part of the multiple subunit or committees of Fever Foundation. Thank you, ma'am, for all your support, and thanks. That's the reason why we are at the 6th annual national conference of Fever Foundation. Apart from that, she's also been the chief of pediatrics and neonatology in Nemcare specialty hospitals at Guwahati. She's also instrumental in setting up the entire center there at Shillong, and she has multiple accolades to her thing, numerous paper achievements, presentations, ardent speaker at various forums. Thank you, ma'am. And it's over to you to take over the session. Thank you, ma'am.
Thank you very much. I thank the Foundation for giving us the opportunity to discuss a very important topic, that is antipyretics. So for this panel discussion, I'd like to invite the panelists, Dr. Showing the CVs. Yeah. So the first panelist is Dr. Sridhar Ganapathy. Good evening, sir. As you can see, he has done a specialization in pediatric sleep medicine from Australia, and presently is working as the medical director of Janani Children's Hospital in Mumbai, has several publications and chapters in peer-reviewed journals and books. I welcome you, sir, to this panel discussion.
Thank you. Thank you.
The speaker is Krishna. The next slide, please. Yeah, Dr. Palani Raman, who is a practicing consultant pediatrician at Tindivanam, which is in Tamil Nadu. And he is active academically, also winning the practicing pediatrician quiz in 2002. His special areas of interest are infections, hematology, and computers. So welcome, sir, to this panel discussion.
Thank you, madam. Thank you.
The next panelist is Dr. Shantanu Dev, who is from my side of the country, and currently he is also been elected as the zone, and he is also a big name in IAP ALS BLS group. Welcome, Shantanu, to this panel discussion. And the panelist is Dr. Tapisha, who is Tapisha Kumar, who is a pediatric consultant at the Max Super Specialty Hospital, also a member of the ID chapter and a lead author in standard treatment guidelines on enteric fever. So she has also faculty in all about fever and rational investigations in PID and evidence base of infectious disease, TOT. So welcome all of the I will start with the questions, which is directed to all the panelists. The first question, that when we talk of antipyretics, what is the main reason that you prescribe an antipyretic in a febrile? So I'll start, Dr. Sridhar Ganapathy. Can you tell me, sir, why do you prescribe an antipyretic? What motivates you to give the drug?
So it's basically the number one would be to bring down the discomfort that the child is experiencing, and then the fever phobia that the parents have. So there is a lot of phobia among the parents that this would cause dehydration. It would affect the brain. The child might start having convulsions. So there is a lot of apprehension. So what is really required is a lot of counseling, and they being taught how to record temperature. And we don't try to achieve normothermia, but we try to alleviate the discomfort that the child has in the form of he's totally swooned up and he's got a lot of body ache, and we just try to bring that down so that he's more comfortable.
Okay. What about Dr. Palaniraman?
Yeah, madam, actually the end point of prescribing antibiotic therapy is not to bring the normothermia, it is only to reduce the discomfort, as well as when the fever rises, more amount of dehydration can occur. So to prevent the dehydration, second important thing use, these are the two important use of particularly an antibiotic therapy. And as Dr. Sridhar told, plenty of counseling plays a major role here.
Shantanu, what about you in your practice?
I agree with both of them. It is mainly to reduce the discomfort. But when fever is of, say, higher grades, so more than 104, etc., and then the chances of putting a lot of pressure on the cardiovascular system and the pulmonary system also is there. So if the child has an underlying cardiac condition or a pulmonary condition, we will probably prescribe antibiotics. Otherwise, it is mainly to reduce the discomfort. And like everybody said, the idea is not to normalize the temperature, is to bring down to a comfortable level, which makes the child more comfortable. The child is able to eat, the child is able to drink.
Okay. What about Dr. Okay, thank you. What about Tapashri ma'am?
Yeah, ma'am. I'll just add a reason. Yeah. I'll just add a small point that it is also important for both parents as well as the doctors to see the child when the child is fever free, because then we are able to assess the disease, the underlying disease. Even if we counsel the parents and tell them, watch how the child is when there's no fever, and when they tell us ki haan, wo to khelne lagta hai aaram se, he's very playful, he's active, that also helps us in diagnosing the because the child's face is totally different when he has a fever of 102 and when there's no fever. So that helps us in diagnosing. And also when there's no fever, the child is able to have some amount of oral intake, and therefore that sort of adds to the general well-being of the child. So that is why we need to decrease the temperature.
So continuing this discussion, I'd like to ask Dr. Sridhar, is it really necessary? Is it really necessary to give an antibiotic?
So that's
and
what
try
I
to
told
reduce
you.
the fever?
Yeah, so I did mention that right in the beginning, that fever is supposed to be a physiological response. It is just trying to stimulate your immune system to control whatever wrong is happening in your body. So you don't want this immune response to be blunted. But like all the other members in the panel did mention, that there are certain places when an antibiotic is very essential. So if I have a cardiovascular or a respiratory compromise, so for every degree rise in fever, my oxygen consumption, my respiratory rate, my metabolic demands go up. So in such a situation, yes, definitely I would go ahead with an antibiotic, because I don't want that happening. Or in a critically ill child, or when the temperature is very high, I would definitely do that. Otherwise, that is why counseling is so very important, to tell the parents that you are trying to blunt a normal thing which is happening in the body to prevent something grave that's going to happen. You do monitor the child. That's something very important, because during the course of the illness only you'll get to know what is the cause of fever.
So in this probably yes, Palaniraman.
Madam,
please.
as you told, evidence says up to 102, there is no need to treat. As to up to 102 degree Fahrenheit, that is the evidence says. But as per the evidence, it's very difficult to practically in the day-to-day practice. But for the patient, we can simply, for the layperson, we can say above 100 you can give start paracetamol, below 100 no paracetamol, because they are more often confused with plenty of 101, 102, everything. So simply we can say easily above 100 you can give, above less than 100 no need to go. But the evidence says up to 102 is beneficial to the patients, and to reduce, to enhance the immunity and plenty so on, so on, so. Yeah.
What about if suppose there is a patient with, Dr. Shantanu, you wanted to add something?
Yes, so this cutoff of 100, at the same time, we should also tell them that if the child is comfortably sleeping and the temperature is maybe 102 also, do not wake up the child to give paracetamol because that is not causing discomfort. So those kind of calibrations of parental expectation and the care that the parent should take at home, we should practice in our counseling also.
Yes, Dr. Sridhar.
Yeah, just an add-on since this numbers were got into play. So we are now in an era of personalized medicine where the fluctuations of 0.5 to 1 takes place throughout the day. So any temperature, even if it touches around about 100 early morning, I'm a little bit apprehensive. And if it is, say 99, I'm apprehensive in the mornings, and 100 and above during the daytime, I would take it as significant. So what we are trying to say is, if I do hand over a thermometer to a parent, I'm going to create more apprehension, but I need to also explain to them. That's why the counseling part becomes extremely important.
Right. So, Dr. Tapisha, I have a question for you in relation to this. Suppose you have a patient in your ICU with a neurological problem or then would you follow the same principles of management of fever?
So I'll just repeat the question. So a child who has an underlying neurologic problem may be causing central fever, or maybe someone who has hypothermia due to heat stroke. Is that right?
No, not heat stroke. Suppose you have a meningitis with raised ICP and this patient has fever. So what would you be more aggressive in managing this fever in this child?
So definitely, ma'am, whenever there is central fever or, neurologic illness, something underlying, we need to definitely treat fever. But as Dr. Sridhar was saying some time ago, I think 100.4 and less than that is something that we should not even think of, treating. There is a lot of fever phobia in the general population, and 99 itself is treated with medicine. So that is something that should be not really given much importance. On the other hand, in the ICU, when you have a child who is, has some sort of an underlying disease, you need to treat the fever immediately so that the other things like insensible water losses, they do not happen, and the renal blood flow is fine, so you have to treat like that. Yeah.
And to add on, madam, actually, yes, particularly in the ICU, when there is a central fever with meningitis or hypothalamic injury, this hypothalamus may not be functioning at all. So cooling blankets, etc., may be needed where your antibiotics may not be working at all.
Yes. So I think there are two various, why I asked this question, that in the OPD practice or home practice, it is mostly counseling, but when you have a patient with fever in the ICU, probably you will be more aggressive because there could be other effects of the fever on the patient per se. So I come to the next question. Dr. Palani Raman, what is your choice of an antibiotic, and you have to justify why do you want to use whatever you use?
One and only one, the paracetamol is my choice, which I have been using for the past 30 years.
What is the reason?
With exceptions, very rarely I come across paracetamol allergy in the form of fixed drug eruptions. I had come across in those times. Initially, I used to use alternative like ibuprofen. Now I am using mefenamic acid as an alternative. That too only handful of cases. Otherwise, 99.9% only paracetamol. So it is a safe and time-tested antibiotic. And with a proper dose and proper timing, nothing will, no need to worry. And I didn't find any difficulty with using paracetamol and convincing the patient also. Only way the problem is the patient will tell the temperature is not settling down. But I will say I am giving the paracetamol not for the temperature to come down, to make your patient little comfortable, not to completely drastically touch the baseline. So that when I tell the patient, then they agree.
Right. So next, I would like to ask Dr. that we talked about, the making the patient comfortable when we are controlling fever. So what is the evidence in the literature of regarding the antibiotic used to enhance patient comfort? Do we have some data talking about this?
Some network issue, ma'am. The question is for?
Rashna, ma'am, we have a network issue there. I think maybe you can switch off the video, ma'am, so that we'll have better bandwidth.
Can you hear me?
Yes,
okay.
ma'am.
Just
It's little breaking, madam. It's little breaking from your side.
okay. I'll just put off my video. Probably there's So this question was for Dr. Shantanu, that continuing with this that we need to enhance the patient comfort. So is there any evidence in the literature talking about this this issue of enhancing patient comfort using an antipyretic?
I have not directly looked at literature, but I think there is, because there is so much of quotation that paracetamol reduces discomfort, etc. So I'm not exactly, I cannot quote a literature, but I think there is, because there is overwhelming mention of it in the textbooks, etc. So I think somebody else, yes, everyone is raising hands, so I think they'll be able to quote.
Yeah, Dr. Sridhar.
Yeah, so I think paracetamol has been studied at different dosings. So it has been at 10 milligram per kilogram, at 20 milligram per kilogram, at 30 milligram per kilogram. And they have definitely found that it is very efficacious in bringing down discomfort and causing good sleep, which is most essential, because as I practice also a little bit of sleep, I feel sleep and immunity are very closely related. So when a sick child tends to sleep well and the irritability is brought down, you have two advantages. The appetite comes back. Hydration is much easier when you don't have the fever. And if you can bring down this sort of discomfort, it is absolutely great. As far as the analgesic property of paracetamol is concerned, it's definitely on the lower side in comparison to ibuprofen and mefenamic acid. It's almost towards the 0 mark. But as far as, I mean, the analgesic is good, but the anti-inflammatory mark is almost 0. So that is one thing. And I was just thinking when Dr. Palniraman was talking about fixed drug eruptions and that he would shift to an agent like mefenamic acid, the only problem of using anything which is very strong, because all these are antiprostaglandins. So when you're talking of antiprostaglandins, what I'm definitely worried about is 1, mucosal healing or mucosal integrity, and 2, I'm worried about renal blood flow because I'm already underhydrated. So when I have two things where my intake is poor, my mucosal healing is defective, and my renal blood flow is, would I jump into something which is really very strong? But he did end up by saying that it is only as a rescue medicine. So that sounded pretty well.
Okay. Tapishi, you wanted to say something? Yeah.
Yes, ma'am. I would like to say that I think the message should go from the discussion that we should primarily think of acetaminophen as the primary drug to be used as an antipyretic. If used in the right doses and as frequently as possible, most of the times it gets the temperature down. I think the fever phobia should not only go from the minds of parents, but also from doctors. Every phone call in which the mother is anxiously talking about 102, 103 should not bother us also. And most of the international society guidelines only talk about acetaminophen, even IAP, at most ibuprofen. We should not be using any other drug. I think there should be very clear-cut message, because NSAIDs can cause a lot of trouble in this today's time of consumer forum, etc. Drug eruption, Stevens-Johnson syndrome, the list is endless. Acetaminophen has such an excellent safety track record that even in the USA, where they have good record of adverse events, they found that acetaminophen over a period of 50 years caused a total of 100 cases of Stevens-Johnson syndrome in the entire USA. And even acetaminophen caused that much. So the numbers from the numbers from NSAIDs like ibuprofen, mefenamic acid may be much higher. Mefenamic acid can cause seizures, and I don't really think we should give the impression that we should be using this drug.
Okay. So the next question again comes to you, Tapishi, that when you're would you also tell the parents that antipyretic can prolong an infective illness or increase the viral shedding? So that's why we should not be very aggressive in reducing the fever.
Yes, absolutely, because definitely fever has some sort of a beneficial effect immunologically. It raises the neutrophil levels. It sort of decreases the viral multiplication because it decreases iron levels, etc. So we shouldn't be very aggressive. However, there aren't many human studies or human to corroborate this. But in my own practice and in our own practice at my hospital, we rarely ever used antipyretics other than acetaminophen, even in dengue, etc. We rarely ever use these drugs. Usually only acetaminophen works well. Even in cases of dengue, we do not use other NSAIDs. So we should be using acetaminophen itself. The temperature comes down to 101 from 103 and the child is comfortable. There's no need to get it down to 98.
Right. Any of the other panelists would like to add to this?
Yeah. So basically the problem with acetaminophen is a very short duration. So it starts off, say, by 1 hour and ends by 3 or 4 hours. That short duration is what causes a problem. So that is why people have tried out combinations which are not rational. So that's number one. And in the chat box, there was a comment by Dr. Pramod. He's an ID specialist. And he's absolutely right in saying that NSAIDs have been linked with, when you have a chickenpox infection and you use a strong NSAID, the chances of you getting a secondary infection with the group A streptococci is very high. So we do know that you are more predisposed to certain infection. You are predisposed to a more lengthy viral infection. A common cold which would have stopped in a day, 2 or 3 would go on for a long time. So it's known with rhinovirus and so also. But again, looking at paracetamol, I basically feel that we are now entering into an era of evidence-based therapeutics, wherein we need to look at our community and see how it works. And the adverse drug reporting in our country is not very good. And if you go through most of the adverse drug reporting that's now coming in, there are some casual reports. I think Dr. Jagdish Chinappa would agree with me. Some linkage between paracetamol and wheezing. There is undescended testes with paracetamol in the mother who's been taking it for back pain. So everything comes with the other side of it. You have both sides to it. So we need to look at the patient. We need to look at comorbidities and decide. Of the lot, yes, paracetamol definitely scores over the rest because it is efficacious. It does not remain in the body for a long time. And drug interactions are almost negligible there.
Rashna, can I come in?
Yes,
I feel that the short duration of action is also an advantage because we are using antibiotic or paracetamol for symptomatic relief, and the short duration of action actually allows us to see the pattern of fever, then which may help aid in the diagnosis. It also helps us to assess the child when the child is febrile or afebrile. So that short duration of action also gives a lot of advantages because we are using it only for symptomatic relief, not as a curative for the underlying condition.
Right. So I'll go this. We have already discussed a little bit on the issue of acetaminophen versus ibuprofen and other NSAIDs. So Dr. Palaniraman, given the choice, you will always use acetaminophen, other NSAIDs.
Yeah, I don't remember whether the occasions when I used the alternative. Hello, am I audible?
Yes.
I don't remember the occasion, particularly for a simple febrile illness, when I have used anything other than paracetamol. But only occasions when I used ibuprofen is mainly when there is associated inflammatory part, particularly when there is cellulitis or lymphadenitis. So where the pain as well as the inflammation is also a major part, I had used ibuprofen as an alternative. Otherwise, I don't remember the occasions when I have the thing. And even though the thing evidence says when some patients may not respond well to paracetamol, you can change over to brufen, but I have not done so far. And even the combination I have not done given so
far. Any of the other panelists would like to comment on this?
So when the inflammatory tone is high, so if you have an inflammatory... Hello?
Yes,
So,
audible.
Yeah. So when they inflammate, like you mentioned, if you have an inflammatory focus, then paracetamol just won't work because the peroxide tone is very high. So it's pointless using paracetamol there. It may be analgesic, but there is no anti-inflammatory effect there. So a prudent choice is definitely ibuprofen. But the problem with ibuprofen is you should know the drug interactions when you're giving it. Because if I am already on a drug like methotrexate or an aspirin, there is a problem. So methotrexate can build up in the body, or the effect of aspirin can be blunted. So these are all very common interactions that are very well known. And now that we are going into personalized medicine, I'm a little bit apprehensive because we may even start doing the cytochrome enzyme system 2C9 because there are variants in our population wherein ibuprofen can start accumulating in the body, and that can give rise to mucosal bleeds and platelet dysfunction. So what paracetamol definitely scores in these things, especially when you have somebody with a lot of comorbidities or if you have a renal condition. Yes.
Okay.
My experience has also been similar. I have used ibuprofen very rarely for painful conditions. For example, a painful tonsillitis or a painful otitis media instead of paracetamol. But otherwise, these are the two drugs only which I have used, and very, very rarely and in very, very selective cases, I have used ibuprofen. It has mainly been paracetamol.
So I think, yes, Tapashri, please.
Just wanted to make a point that whenever we have a patient who has some sort of a circulatory dysfunction like dengue fever, those are the patients who have very high temperatures. There's often a tendency to use something aside from acetaminophen. So 2 points are important. I think most of us are already aware of it. I'll just make it short. One is that we all know that ibuprofen and mefenamic acid can alter platelet function. That's first. The second thing is that circulation, if any circulatory dysfunction, the renal blood flow is being maintained by prostaglandins. So when we give NSAIDs, there is prostaglandin synthesis inhibition peripherally, whereas acetaminophen mainly does central inhibition of COX-2 pathways. It is ibuprofen or NSAIDs which do peripheral inhibition of prostaglandins that can actually impair the renal blood flow and make things worse. So it's very important that in such fevers, in critically sick children, these medicines are not used. That's the point I wanted to make.
NSAIDs like ibuprofen or even naproxen would only be for the inflammatory fevers, like when you have a rheumatological condition. So you have an arthritis, a juvenile arthritis, which is very painful. With fever, then only probably you will use. Otherwise, we will go with the safest drug, that is acetaminophen. So, Dr. Sridhar, what about prophylactic antipyretics when you're giving the? What is your thought on this?
So I just couldn't.
Not able to, madam.
You
Not
went
able.
off the line. Prophylactic antipyretics for
vaccination.
Okay, so again, like I mentioned right in the beginning, that this started off with a study, I think way back in 2006. I think it starts with Pyronel. He came out with a study that giving prophylactic antipyretics, analgesics during vaccination can blunt the antibody response. But what was seen is during primary vaccination, when you give these agents, it does blunt the antibody response, but post-booster, the seroprotection levels are not affected. So suppose 2 is your protective level, it may bring it down to a certain factor, but not up to 2. The other side of using an analgesic antipyretic during vaccination is you get better sleep and you're more comfortable in that 24 hours. But then the drawback is we all do know that you need the immune system to room into the antigenic site. And when you use something which is strong, other than a paracetamol, definitely this rooming in is prevented and you could blunt the immune response. So there is both sides to it, but definitely one thing has been mentioned, that you should not be giving it prophylactically before the vaccination. So there are many centers where they ask you to take the antipyretic, say 3 to 4 hours before you come for the vaccination. That's not done. So we usually use hot fermentation or locally ice, and we tell them that if the child is in tremendous discomfort, pain, there is a little bit of induration, because now we know that any induration that comes initially is faulty injection, that probably you didn't wait for the antiseptic or the spirit to dry and things like that. So if everything is done well, usually you don't get a reaction, but this used to happen with the whole cell, we still get quite a lot of reaction. So what is essential is you give it on an SOS basis to reduce discomfort. That's my take on it.
Anybody else wants to add to this?
Yeah, I agree with Dr. Sridhar. We should not use it prophylactically, but only post-vaccination. If there is fever and discomfort, we can use it.
Okay. Then I come to Shantanuda again. I wanted to ask you, what about this combination? Ibuprofen, paracetamol, ibuprofen, mefenamic acid, paracetamol, acid. What is your take on these?
The combinations are actually irrational because they do not have synergistic effect and the side effect doubles. So basically the same thing which could have been treated by only paracetamol, you are giving 2 drugs now, and you are giving at the cost of the side effects of both the medications. So that is risky, and they are not, these fixed drug dose combinations do not come under any essential list of WHO and are to be avoided.
Right. Yes, Dr. Sridhar.
The adjusting the dosing becomes pretty difficult.
Yes.
So that is one of the main problems. So suppose I do know that paracetamol works on a COX called COX-3 in the brain, and the ibuprofen works more in the periphery as well as centrally. But paracetamol penetration into the brain is much better than that of ibuprofen based on its hydrophobic and hydrophilic properties. So we do know that the combination could be beneficial, but what happens is now we are talking about cumulative toxicity. So we have cough mixtures which have paracetamol, we have analgesics which have combinations. So the total amount of paracetamol that ultimately goes in is tremendous. And we are not calculating paracetamol properly. Neither when you're giving a mefenamic acid with paracetamol, again, mefenamic is 6 to 6.5 and paracetamol is 10 to 15. So when you really look at this and there is a parent who's just worried about the fever and there is repeated dosing, the cumulative toxicity could be detrimental for the well-being of the child. So that's one of the main reasons why fixed drug combinations should not be used. You have the liberty of using, you can even stop paracetamol and use ibuprofen like Palni Raman was saying, if you're not very comfortable and you feel that, yes, I need to do something more.
In this context, where as I was telling, as Sridhar was telling, mainly we have to insist the patient monitoring the sickness and behavior of the child is more important rather than the monitoring the temperature. Because crashing down the temperature is not possible with paracetamol. It mainly reduces, even with the ibuprofen also, only 1 to 2 degrees centigrade, but it won't crash down. So we have to explain the patient monitoring of the sickness and monitoring of the behavior, activity and hydration and urination, everything is important rather than the monitoring of the temperature around the clock. Because of the IT parents nowadays, they are more on mainly with respect to they are chasing the temperature and chasing with the paracetamol. That is not a good idea. We have to counsel them. That is not at all important with respect to the thing.
Also, it would be a good practice for the caregivers to note down the temperature and the time at which they are giving the medications, especially if there are multiple caregivers, because there would be heightened anxiety and they would end up giving a lot of paracetamol if they are not noting down the exact times at which they are giving paracetamol or any other antibiotic. The caregivers would end up giving a lot of drugs.
So 2 things I always insist. One is sensorium, like Palni Raman said, and the other is urine output. That is something which, and with the diaper, in the diaper era, it becomes very difficult. So you need to tell them that. And I totally agree, maintaining a temperature chart and putting an arrow whenever you have used an antibiotic would go a great way in helping the other person know what is happening.
Okay. Yeah, I think so. We've touched on some very important points. So I wanted to ask Dr. Raman, what about the antipyretics that we use for febrile seizures? Does it really reduce the incidence of febrile seizures?
Evidence clearly says no, madam. And also sometimes the problem occurs sometimes even
what about the dose? Do we need to increase the dose?
No, definitely. Even with the onset of the fever, sometimes the patient comes with the seizures, then afterwards the temperature rises. Sometimes happens like this. So definitely there is no correlation between using the paracetamol or any antibiotics to reduce the febrile seizures recurrence. There is no evidence, and it is clearly proven, and we have seen practically also.
So, yes, the people to add something.
Yeah, just wanted to make a point, ma'am, that we are very clear. I totally agree with Dr. Palani Raman that the use of antipyretics will not decrease the seizure recurrence in the next episode, because the seizure is related to how fast the temperature rises. However, it is known that in the first episode or in the current episode, if you give round the clock antipyretics for next 24 hours, then there is some decrease in the possibility of another seizure happening in the next 24 hours. There is a beautiful open trial in Japan, which has taken 400 children, and they've had two groups, one which received antipyretics for the next 24 hours after the first febrile seizure, and the other group did not receive anything round the clock. And the incidence of a second seizure happening was less in the first group. So there is some evidence that in that particular episode, it may decrease the recurrence, but definitely not the next. For example, if he gets fever again after a month, you cannot just start round the clock antipyretics and think that it won't happen.
Yes, Dr. Sridhar.
Yeah, just an add-on. So it was during this period when we had this fever, phobia, and febrile convulsion that the suppositories came into the market, and there was so much of excitement about the suppositories. And the problem with our country is the temperature. So if it is kept outside, it's no longer in the solid state, and when you re-solidify it, the distribution of medicine is totally different. And then there are people who cut it into many pieces and then insert it, and the absorption is absolutely erratic as far as the rectum is concerned. So I just wanted to state this also, because that is also another way of treating febrile illness, and a number of people indulge in this usage of suppositories. Because especially when you're having high fever and you're vomiting and you're not in a state to take something, we also have this melts or liquid films that we get, which are very useful, but you can't put in too much of medicine into it. So you get only the 125 strips. But otherwise, the suppositories, we need to know about the other side of it.
Yeah, in fact, you've covered a question already. I had one question for you on suppositories, so you already covered that. The next important thing is, what physical therapies? Do you want to use any physical therapy, Shantanoda? Suppose you want to advise, give paracetamol, it doesn't work. What about the physical therapies?
See, it is always to reduce the discomfort. The overclothing should be removed. The child should be put in an airy room with a lot of circulation of air, which will all help in temperature reduction. Tepid sponging also may help, but there are these effects are not long lasting, and there is not so much of evidence to say that they help, but they make the child more comfortable. For example, tepid sponging can also lead to more shivering, and the child may start having higher temperature also. So all these things need to be kept in mind, but of course they have some role in reducing the discomfort. But the one of the important non-pharmacologic therapies is hydration. Allow the child to drink a lot of water, to remain hydrated, because a lot of insensible water loss occurs, and the child should replenish himself or herself, because hydration is a very good antipyretic. So these things we need to take care of.
Actually, with respect to tepid sponging, usually there is a clear-cut evidence not to substantiate tepid sponging anyway, but still it has some role, particularly in hot countries like India, particularly during summer, when we come across fever patients, when the ambient temperature also plays a role in increasing the body temperature. So we can ask them to give tepid sponging. That is the only indication I feel we can use a tepid sponging in summer in hot climates like India. Otherwise, it has no role as such. As Santanu told, it mainly increases the discomfort rather than the thing. And clearly, we have to say the patient that 30 minutes before the paracetamol has to be given, followed by tepid sponging, all the things. But definitely, they won't follow these advices. That is the thing.
Can you predict the type of infection on the response to antipyretics? Did you get can you hear me?
Yes, madam. Yes.
Tapisha, this question was for you.
Acha. So, ma'am, I wish we could, but I don't think it's really possible. Yes, of course, sometimes if you are treating, for example, say, an enteric fever and the child starts showing some response, you know, the temperature will come down faster. But at the outset, I think it's very difficult to predict whether it's a viral infection or a bacterial infection on the response to the antipyretic. That's my take on it.
On that?
Sridhar, you can. Sridhar is
so just an add-on to what was discussed, the previous question. I just thought that we all do know conduction, convection, evaporation, they all bring down the temperature. But the problem is whenever you try to bring it down by these methods, like the grandmother's technique used to be the Eudicolon handkerchief in water kept on the forehead, and then came the tepid sponging, and then came the big fans, and then came disrobing. Now the problem is if you bring up the sympathetic tone, if you bring up shivering, you are going to add on to fever. And in a pyrogen-induced fever, like an infection-induced fever, it is a set point which is at a higher level. So there is no point doing this without an antipyretic. So like Palniraman was saying, yes, you need to tell them that this could be an adjunct, but the role of the antipyretic has to be mentioned. So this is, you disrobe the child, you keep him in a well-ventilated place, hydrate him well, but you need to give the antipyretic because you are working on the set point. This is not like a heat stroke where it is something totally different.
Yes. So which means you.
I'll just make a short,
very antipyretic and. Pardon?
Just a small comment. If we want to do combination therapy of any kind, it's the ideal thing is acetaminophen plus sponging.
Yes.
Right. Okay. So we'll go to the next question. This is for Dr. Sridhar. What are your thoughts on the use of?
Madam, not audible, madam. Not audible.
Not audible. Can you hear me now? Yeah.
Yes.
Yes.
Yeah. Dr. Sridhar, what are your thoughts on the use of aspirin in children?
Aspirin went out of the market. That's when paracetamol took over. And the paracetamol has been like Carl Lewis, way ahead of the race. But then we need to, because see, as data accumulates, we get to know more and more about many things. And aspirin is used to be an irreversible blocker of the cyclooxygenase pathway or the prostaglandin synthetase pathway. So it had its full bucket of side effects. And when the Ray's syndrome came over, it went out of the market and it was more into the cardiovascular basket rather than in pediatrics. So we still use it in a number of other conditions, but not as an antipyretic. So aspirin, no, not at all.
Palniraman, this is for you.
Okay.
What about the side effects of paracetamol?
Paracetamol side effects. It's
all side effects that we need.
Mainly, depends on the counseling of the parents. And if the parents, particularly parents, are of attitude to crash down the temperature from 104 to 98, the problem we already told, it won't crash down with the paracetamol. They say the temperature reduces for 1 hour, again the temperature rises. If they start keeps on giving for more than 8 to 10 doses, like cumulative toxicity can occur. Number one, this is the way cumulative toxicity can occur. Number two, the problem with mainly the preparations. Sometimes the people use the drops which are of higher concentration as an ml in the form of spoons. So there the problem rise, or like P500 like medicines. So where there is also a problem. So we have to be specifically cautious about the preparations they are using so that This mainly the toxicity is avoided. Otherwise, in conventional doses of 10 to 15 milligram per kg for maximum 5 doses per day, it is very rare to see. I had yet to see a paracetamol toxicity with respect to thing, except for a patient like as already told, had taken inadvertently drops as a form of syrup and came with the paracetamol toxicity. Otherwise, I had not seen the thing.
Yes, Dr. Sridhar.
So when you go through the toxicity of paracetamol, there is a word of caution. And the word of caution is if you are going to be using between 3 and 6 months. So the metabolism is more of a sulfation pathway. And this can be blocked by the microbes that you are having in your gut. So there are certain microbes that produce a lot of P. cresol, like the Clostridium, which can block the sulfation pathway and can predispose you to paracetamol toxicity. But the advantage is the therapeutic window is so huge that getting toxicity is something unheard of. That's number one. Two, the second thing that is mentioned in our pharmac textbooks is if you have a malnourished child, a severely malnourished child, or if you have somebody who's totally wasted, or in an alcoholic, or somebody on HIV treatment, or somebody receiving anti-tuberculous drug, these are cases where the chances of toxicity are high because the sulfhydryl group in their system is less. So the toxic metabolite of paracetamol comes through a cytochrome system. When it gets overloaded, when glucuronidation gets overloaded, it goes to that and you get a NAPK, which is very toxic. And this NAPK is taken care of by sulfhydryl. So when you are deficient, like 3 and 6, malnourished, HIV, and undergoing treatment, AKT, this is where you give a lower dose. So you don't go to straight 20 milligrams. You start with 10 and you can build up to 15 if the baby does well. But you need to be careful, like Palani said, look at the prescription in total. See that there are no paracetamol in other preparations, like a cough, a preparation for the nose which has paracetamol and things like that. Because cumulative toxicity is very well known now.
Right. Yes, Sataruna.
Yeah, the textbooks mention the toxic dose of paracetamol to be above 90 to 100 milligram per kg per day. So if a child is taking 15 milligram per kg 4 hourly, that means 6 doses, that will reach 90. So we need to be a bit cautious while prescribing, but we also need to remember that paracetamol is abundantly available over the counter, and the parents, they instead of a 120 mg preparation, they'll use a 250 mg preparation or a 500 mg preparation, and then they can land up with paracetamol toxicity. So danger is there, but we need to be more cautious while explaining the prescription to them that we write.
Okay, so continuing this toxicity issue, what about IV paracetamol, Dr. Palaniraman?
Yes,
IV paracetamol.
IV paracetamol is mainly used for the post-surgical pain relief and other things. I don't think we are regularly, as an office practitioner, I used so far in my knowledge with respect to now. I had never used, madam. It is mainly the post-operative analgesia. It takes very nice compared to the previous analgesics. So that is the reason now, right and left, it is mainly used in the surgical wards, paracetamol, IV paracetamol.
The IV paracetamol dose that is mentioned in textbooks is not 15 milligram per kg. Till infancy, it is 7.5 milligram per kg per dose. So that is half the dose till infancy. And with the widespread availability of IV paracetamol, we are seeing a lot of misuse in our hospitals, in the emergency departments, etc. Children, they start getting IV paracetamol also. So these dose needs to be kept in mind. It is half the recommended dose of oral paracetamol.
Because the therapeutic window is huge.
Yes.
So the chances of problem are very less. That's number one. And number two is the analgesic property is something really very good. So since it is safe and doesn't accumulate in the body, and analgesia is so good, it's used on SOS basis post-operative also. So there is one pre-operative, and once you come out, it's kept on SOS basis. Much better than the others. And now we have the ibuprofen also in the market.
And madam, as Dr. Sridhar told, adding to the malnutrition and other factors, even in South India nowadays, for during dengue season, people advise, particularly intensivists advise to give 10 milligram per kg instead of 15 milligram per kg. Why? Because the dengue, particularly third day, fourth day, they're more prone for going for shock and hypoperfusion of the liver. So it can add to the injury, liver injury. So they are not advising, particularly from the third day onwards, the 10 milligram instead of 15 milligram nowadays in South India.
So the other thing, I think, a very important point is we have to tell parents about the side effect, the nephrotoxicity of ibuprofen, drugs like ibuprofen, because many a times they really, over the counter, they will go and buy ibuprofen and give for fever. So I think that is an important as far as the side effects of NSAIDs that we have to talk to the parents about. So I think we have covered most of the points. The only issue here, I think, yes, Dr. Raman.
Madam,
yes, please.
And particularly when OPD patient comes, usually we advise this round-the-clock paracetamol, either 6th hourly or 4th hourly or 5th hourly. It is only for the first 48 hours. Because most of the benign illness are mainly the 48 to 72 hours. Beyond that, we have to know what is going on. So we have to know, we have to tell the parents, after 48 hours, there is no meaning in giving round the clock. They have to give only when the fever arises. Then only we can know whether the fever is the rising trend or it is a lowering trend. Otherwise, they will keep on giving this round the clock paracetamol. So only for first 48 hours, this round the clock paracetamol is advised, not beyond that.
Right. So I think we've covered most of the points in our antipyretic discussion. I'm asking all of you, suppose you have a patient with a paracetamol allergic skin rash. Then it is said that if they have an allergy to paracetamol, agents also, how do you manage the fever in these patients?
So I was using mefenamic acid, madam. Initially, I was using ibuprofen. They told like paracetamol, ibuprofen is also more prone for the same thing. So I was using the recent past. Hardly I have around 5 to 8 cases of fixed drug eruption following paracetamol. So I am using for those patients mefenamic acid. And mainly when the temperature is more, not for the up to, I'll advise mainly go with the supportive measures up to 102 or 101. Only when it is beyond the control, you go for the mefenamic acid.
No, there is no cross-reactivity between paracetamol and ibuprofen. And ibuprofen, now you can do CYP2C9 variant analysis. If you have those polymorphism, then it is risky to use because there is buildup of ibuprofen and you can get any reaction, right? From a skin reaction to a renal toxicity or anything. So you could very well do that. Because if you could tolerate mefenamic acid, which is a phenamate, you could very well tolerate a propionic acid because it is one step ahead of, before this thing. So I don't think there should be any problem using an ibuprofen. But the teaching is, when you are hypersensitive to NSAIDs, they all come under an umbrella, this thing, because they take care of the COX pathway. And you don't want them getting into the LOX pathway or the POX pathway, which can be activated and you could get a reaction. So you have to be careful whenever you have a substitute for paracetamol. And you have to confirm that it is definitely paracetamol and not an additive in that mixture, because we have had a reaction to methylprednisolone. And it was an anaphylactic reaction. And that is because the methylprednisolone had lactose in it. And this child was cow's milk protein allergy. So you need to know all about your drug before you jump into it. Just like when I write a paracetamol, I hardly tell my parents that you have to take it on an empty stomach. Because whenever you give them something like a paracetamol, they feel khana khane ke baad hi lena hai. So you need to take it on an empty stomach for more bioavailability. Same thing with an ibuprofen. The best bioavailability is when you take it with Coke, but I wouldn't be advising them to have it with Coke. So what I'm trying to say is you need to know about interactions outside as well as interactions inside before you pen down a drug. I think it's time that we start respecting our body and our drugs.
So I think we are, Dr. Krishna, I think we are, we have completed.
Yes, ma'am.
Panel discussion. We've had a very good discussion. I think we could continue having this discussion on antipyretics for more hours, but I'm very thankful to all my panelists. I think the main point has come out of this discussion is that fever phobia, which is there among us, that should go off. Then only we will be able to remove the phobia from the parents and use drugs judiciously. And of course, the drug of choice remains acetaminophen or paracetamol. So thank you very much to all my panelists. I'm very grateful to your contribution. And I hand to Dr. Krishna.
Thank you, ma'am. Thank you, Rashna ma'am, for the wonderful moderation of the session. And also, we thank all the panelists, Dr. Sridhar Ganapati sir, Dr. Palaniraman sir, Dr. Tapisha madam, and Dr. Santanu Dev sir. Thank you for the wonderful insights and the clinical pearls there. And I hand over the session to Dr. Anand Vasudev sir and Dr. Jagdish Chinnappa sir for the final remarks for the day.
So I just wanted to thank Dr. Jagdish Chinnappa, Dr. Krishna, and the Fever Foundation for having us here today. Thank you so much. Thank you. And thank you. This is from all the panelists. From all the
Really a
panelists.
good learning exercise for us.
Yeah.
Sridhar, you have given plenty of points.
And that last line which I'm going to tell you is going to shake you up. Mefenamic acid came into prominence during COVID, where they showed it had an antiviral property. And it was combined with ribavirin. So what I'm trying to say is, you are all going to be in for surprises. It is only with time you'll know what it is. All the reactions could be idiosyncratic reactions. So let's wait and watch, and whatever suits somebody, use that, but know the other side of the medicine.
Yeah, my friend has seen a Steven Johnson with mefenamic acid. My friend has seen a Steven Johnson with mefenamic acid.
Hemolytic anemia, they have seen. We have seen seizures, so many of them.
And I have seen hematuria, gross hematuria in these patients. And in one nursing home, I saw 4 cases in 1 month, same combination given for fever by the same pediatrician. Then I requested him that please stop it, otherwise we are harming our children more. And it was an excellent session, lot of learning. And I think all the panelists had done so much of homework that it was very informative session. I think it's a big applause to all the panelists as well as Dr. Das, Rashna Das, for conducting it so very efficiently and smoothly. Thank you.
Thank you.
Jagdish, waiting for your comments.
Yeah, thank you very much, all the panelists and Dr. Rashna for that wonderful session. And I think I learned a lot of intricacies of pharmacology, which I didn't know anything about. Thanks to Dr. Sridhar Ganapati, and of course, Dr. Palniram is the man for the masses, and he repeatedly was talking about how to counsel and how to take care of patients in small places. Dr. Shantanu was, with his immense experience, gave his points. And for the first time, I heard Dr. Tapisha. Dr. Tapisha, being an intensivist, gave a very, very good perspective on how you handle fever in circumstances that are difficult. So it was a wonderful session. Thank you very much, all of you. And I must congratulate the scientific committee which put this idea into Dr. Rashna Das's head. And Dr. Rashna must have really labored to see how to keep all these 4 real horses who are running to, participate. And the enthusiasm was infectious. And I really loved the wonderful way in which it was conducted. Thank you very much, Rashna ji, for your effort and how much of, all the great things that you put in together. And I hope we can have a very, very good takeaways from this. And I would request Dr. Manjula and Krishna to coordinate and try and put all this into a kind of a document so that it is of useful to everybody. And please also send it to the panelists for their expert comments so that they can add some of the things that they might have missed out, or we might have missed out paying attention, because it was an intense session, so we could have missed a few things also. So we could get their inputs before we do it. Talking about the previous sessions, Dr. Pramod was just excellent. Again, a wonderful session on the basic pathophysiology of fever. Really excellent, and I must congratulate him for putting together that talk. The other two sessions were also very, very informative. Dr. Padmasini on the viral fevers and how even a simple viral fever needs to be looked at in so many different angles. And Ravi, in his imitable style, he's got a style of his own. He brought out all the beautiful pictures that he had collected and put together. And really, it's a great learning experience. Congratulate Dr. Manjula, Praveen, and Krishna for all the wonderful technical support. Really, thank you all for a lovely evening.
Thank you, sir.
Thank you, sir.
Over to you,
Sir.
Krishna, Dr. Manjula.
Dr. Krishna.
We thank all the delegates joining in today, and thank you all the faculty speakers and the chairperson for the wonderful day 2 session of the 6th annual National Conference of Fever Foundation FEFCON 2023. And we look forward for tomorrow's session. Tomorrow we have the breakfast session, the Sunday morning session on a very nice session coming up at 9 o'clock tomorrow. Please join us for the breakfast session, which is Mastering Diagnostics Clinicians Dilemma. And also followed by, we have 2 different halls again breaking up tomorrow, physicians in the pediatric hall. I request all the delegates to join by 9 o'clock tomorrow. Thank you and good night.
Thank you all and good night.
For the breakfast session, we are waiting for the virtual breakfast, or it will come on the table?
Mr. Praveen Singh to answer this question.
Yeah, I'll be there.